Do you have admin rights on this?
NHS laptop? Seems unlikely.
I've done the fault finding. As far as I can see, it can see your device from our network. I don't know, like VPN.
The
devices. And
So, first of all, fire. There's no planned fire alarm today, so if the fire alarms go off,
It's here.
we
It's not
follow
quite set
the
up. We're
fire
going
exit signs. It's here, 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 and here. And then
bag.
gather out the front there. The morning tea and coffee, you don't have to go back down to the marquee. It's going to be served at the back of the room.
Let's cancel that. See if we can do it one file at a time.
And that is around about 11 o'clock, hopefully all going well. In your packs, you have the biographies of the speakers, and we hadn't planned to get up and introduce all the speakers. There's various cards, but of course I think the running order might change slightly. So if the speakers introduce themselves, and then people can look in the packs at the biography who's actually talking. So in your packs, like I say, I've asked you to have a look. There's various things that you can have a look at in the packs, going on the QR codes. We're particularly keen for you to give the feedback on what you think of when you hear the word research, and there's various other bits and pieces you can have a look at. We were hoping to put in a Q&A session before lunch because one of our speakers is unable to come, so Yvonne Manson won't be talking today, but with the way things are going, I think we've now lost that time that we'd caught up. And if you don't have a coloured sticker to indicate which workshop you're going to during registration, if you get that during lunch break. And lunch will be back down in the marquee where you can look at the posters and the various stalls and things. There's during the workshops, there's 3 workshops going to be happening. There's the chip workshop, the iris workshop, and the arch workshop, and all the information for these workshops are again in your pack, so they'll tell you about what the workshops are all about. And Neil and I are going to be acting as timekeepers for that. And at the roundup and close, everybody's welcome to stay in the zoo until close at 5, and there'll be takeaway tea and coffee at the top here. And you can take your tea or coffee and go and have a look around the zoo for free. So take advantage of that. There's various bits of research and action going on. There should be the walking speed, and that's going to be, is it going to be in the marquee? Yes, in the marquee. And people are looking for feedback on various bits and pieces, which you'll find again in the marquee, and some on the QR codes in your pack. And I just want to sort of say a huge welcome to everybody. Thank you for coming. It's just fantastic. This is our first ENRICH Conference. And we'd particularly like to say thank you to the CSO for funding ENRICH, which has been, that's enabled us to put this conference together. So thank you very, very much. We seem to have a bit of our first presenter. I'm ad-libbing now, so Jenny Burton, thank you.
As long as Leslie's not counting my time. You sure? Honest? Okay. All right. Well, thank you very much, everyone. And as I say, in unchanged to the programme, you've got me up first. So it's really great to be here talking about the positive contribution that research can make in the lives of people living and working in care homes. Like other people today, I'm going to be sharing some of my own experiences and things that I hope will be of interest. So I am Jenny. I'm a doctor in training, so despite qualifying 12 years ago, I'm still not fully qualified. I split my time between these 2 large teaching hospitals in Glasgow, where I'm training to specialise in care for older people, but I also do research, and since August of last year, the Chief Scientist's Office were funding me for half my time, so half my time clinically and half my time doing research. And my absolute passion is around care homes, unsurprisingly, by being here today. Now, when researchers give talks like this, we often have a slide where we include our declarations of interest. Usually these are about who's paying for us and how that might affect the content. But this is my declaration. I want to live in a world where no one fears moving into a care home. This picture is Alison and Ivan making me stand in the V&A last month, talking to members of the public about this vision. But I guess it's really important for me to acknowledge that bias. It comes from my professional and personal experiences of the really pivotal role that care homes play in supporting people with complex needs, but it is a bias nonetheless. But it's what motivates me to do what we call mixed methods research. So I do work that involves data, but I also do work that involves speaking to people who are involved. This picture has been created for me by the lovely graphic designer Claire at Listen, Think, Draw, who's been trying to help me put some of my initial research findings, where I've been out speaking to the stakeholders involved in care home data, into kind of something more graphical, because let's face it, no one wants to read my long, lengthy reports. This is the Health and Social Care Standards, which were introduced to me by people in this room, as opposed to anything in my training. These are the guiding principles, the established outcome measures of success across our services. But is this, you all capture data on this, you can all evidence how you're supporting residents to achieve this, but is this what services and the system measures? Is this what our data captures and collects? The question I would say is that the care home data landscape probably looks a bit more like this. So a key thing is to say there's lots of data, there's not a lack of that, but it is very siloed. There are lots of people interested in it, and not all of them should see all of it. But at the moment, there's a big gap in terms of, are we evidencing the things that we agree are important, and how are we working across the system to reduce duplication and gain useful insights into the care that's being provided. So, routinely collected data has become a bit of a trendy area for research, particularly in the health sphere over the last decade, but with more emphasis on trying to bring in data from other sources. The attractiveness is this information's being collected. Every time you go and put a prescription into the chemist, that generates data that can be used for research. And because of things in Scotland, we can join that up and look at wider aspects of care. It's thought to be more real world and inclusive than some other forms of research that involve recruiting people. There is a thought that it is potentially more timely than going out and recruiting people and following them up for years and years, and it therefore comes at lower cost. And as I say, this advantage of joining things up to look at things that are maybe more complicated than what you can look at in a single study is very much touted as the benefit. There's a huge investment been put into national infrastructure to do this in a secure way. So I don't get to download care home residents' data on my computer. I access it through secure data safe havens and portals to allow me to do this work in an anonymised fashion, but still look at it at scale. And in order to be allowed to do this work, I had to show that somebody thought it was of public benefit. For care homes, there is an attraction potentially in making use of routine data. Now I start, before Neil says anything to me in his question, that we assume that this data is already being collected, it's already part of the system, so it's already there. And this is then about reusing that information to reduce the burden that is created to others in the system. It is potentially advantageous because it doesn't involve me turning up with my clipboard coming to ask lots of questions. And it is inclusive because it means all residents can be included irrespective of whether they've got someone to give consent on their behalf. And as I say, there's the ability to join it up and put it together with wider bits of the system because we know that residents don't exist in isolation from everything else around them. So let me take you back in time to 2015 when I was starting my PhD, that I wanted to focus on pathways into care, people moving into care after they'd been in hospital, something that in my professional practice was quite common. So I was really surprised to discover that there's quite a lot of national policy that says this shouldn't happen. People shouldn't go into care homes after they've been in an acute hospital. I think that would not really chime with certainly what's happening just now. Interestingly also, there's this health and social care integration indicator that says this is really important and it's something that the system should be able to measure. So this is where we come to my slightly enigmatic title, where I started on a journey uncovering the invisible, because I thought we knew who our care home population were, and we had really good data that would help us to look at this at scale. And although there are flags and there are systems, we don't, essentially. I could probably give you another half an hour's talk on all the reasons why we don't know and the problems with primary care data, the problems with hospital data. But suffice to say, the data are so poor, we can't report on that integration indicator because we don't know where people come from when they go to hospital and where we send them when they leave, which I think is a fairly damning statement of where we are in terms of the data that we have, given how much of it is in the system and given how important the people living in care homes are. However, we do have to, if we think about changing this, we also have to think about being able to measure what matters, not just what we can count that needs the context wrapped around it, like going to A&E, for example. So it's with all of that in mind that back then, 7 years ago, I started doing this study, which didn't have quite such a nice title or an acronym at that point. But I started to look at whether we could use an existing data resource to look at pathways into care in Scotland. And I wanted to look at people going in from hospital compared to those going in from their own homes to say, well, are these people the same? Are they different? What happens? And essentially, I took the Scottish Care Home Census, which may be familiar to many of you as a time that you spend every year filling it in. And I guess it's an opportunity to say this data has been really valuable. So we took all of the data from 2013 to 2016 and we linked it to a whole load of health data sources about people's prescribing, whether they'd been in psychiatry, whether they had been in hospital, other conditions, bits of information. We looked at whether they came in from hospital or from the community elsewhere, and we then looked at outcomes that they might experience and whether those two groups were the same or different. Now, what we found will not be of a surprise to anyone in this room, but it is really important. A, because it's the first time that someone has been able to do this and look at the care home population at scale, and 24,000 is quite good scale. But B, because discovering that these people are different is really important if we want to think about how we plan to support them and what we need to make pathways into care better. Because if we assume that hospital doctors are just diverting people to care homes because we don't want to send people home, which I have been told previously as the reason for the variation, then we're not getting to these different needs that this population have and how we can help people. In terms of the pros and cons of the data, as I say, I won't go through all of these. I think the key thing is about this starting a conversation about the data that we need as opposed to some of the data that we have. And I also think it's really important that we acknowledge that as we stand just now, although we have this great social care data resource in the care home census, when we put that into the system, what we get is lots of health measures. So even the care home census itself does not have a lot of measures about the person, about their care, about social care things that are important. So what we get is lots of things about their health, which are important, but not the whole story. And it was a great pleasure earlier in the month to go to Wraith and be hosted by Alison and her lovely team, where I combined two of the things that I love, baking and talking about care home data. And I had the chance to speak to residents and relatives about their current contemporary experiences of this, because having taken 7 years to get the data together, I want to check that what we're doing now is important. So if we fix this, is it great? Are we totally sorted on people coming into care homes? Do we know how to support people from hospital? Or are there still things that we can learn? Are there still things that research has a role to contribute? So that was the question I was asking them. And it is the question that I would like to ask all of you. I have a poster in the marquee, I have pens, I have blue tack, I have postcards. And I would really like to hear from you, because you have expertise in supporting people as they move in. You've seen their journeys. You know the differences in these populations. What do we need to make this better? What are the things that matter? And how do we get that into the system and into the conversation instead of just focusing on the delayed discharge, people need to get out of hospital, doesn't matter where they go, when they go, how they arise there. So really like to hear from you. In terms of some other things, so during the pandemic, I was really fortunate to be involved in producing these infographics and videos, which were developed collaboratively, again, with some people here and others in the sector. The one that's on the right of your screen is about helping staff in acute and emergency care to better make assessments of residents when they present to their services. It's been developed as a teaching resource primarily to help sort of bust some of the myths about care homes for staff who have no experience in that setting. But a lot of it is about promoting that interprofessional communication and shared decision making that we know results in better outcomes for residents when they need to draw upon these services. Then we have the listening and learning study, which again some of you have very kindly participated in. This was really motivated by the fact that although I've been involved in some of the numerical data-based analysis of outbreaks, that the stories around those numbers are really not being heard and haven't been captured. And if we really want to learn from the experiences in the pandemic, we have to hear that and put that together. And so again, Maria's very kindly been helping me. We've interviewed 34 staff and we hope to have some results to share with you in the months ahead. I guess finally, the other bit of work, as I say, has been trying to look at, well, where are we now? We're collecting lots of data. The pandemic has changed that with the invention of the huddle. What do we need? What are the kind of key principles? What do we need to do moving forwards? And again, a lot of you have very kindly contributed to interviews. And in the early part of next year, I hope to come out and visit people and start ranking some of these priorities, working out what the important things are, because data's not going anywhere. The demand for it is not going anywhere, but there is a need to shape what that data is and what it looks like and what it tells us about the system. So again, I'll be looking for more help with that, I'm afraid. This is a bit of a sales pitch. I think there might be a lot of that today. So I hope I've convinced you that there is a role for data in helping us better understand the people who live in care homes. And I think clearly I've got some priority areas of things I think where we could do with having more evidence and understanding. But ultimately it's the bit at the bottom. Evidence-based services and pathways that support older people informed by real data from real people that measures what matters to them. And that's what I'd like to leave you with today. So thank you very much. Really keen to hear from you all and come and visit me.
Thank you very much, Jenny. Could I ask Michelle to step up to the podium, please? And what I would suggest you do, if you've got any questions, comments about any of the presentations, to go by Slido. So I'll give you that code once more, which is 3253423. Thank you, Michelle.
Do we know where the presentations are? Sorry, I don't know where you've saved them.
You guys are all used to doing things at the last minute and working out what works in any circumstance. So we're actually on this laptop here.
Or you're on this one.
And this is yours here, isn't it?
I'll just put it down here. Thank you very much.
So we're just moving the programme around a little bit just to use the ones that the people that have got their slides locally, we're just having problems accessing them remotely. So we're really grateful to you, Michelle. Thank you very much.
Thank you. Good morning, everybody. My name is Michelle Beattie, and I'm a senior lecturer in the Department of Nursing at the University of the Highlands and Islands. But interestingly, I'm a nurse by background, and my first job, many of you will be too young to remember this, but a YTS, or a youth training scheme, was in a care home. And working there actually really reaffirmed to me that nursing was exactly the career I wanted to pursue. So almost gone full circle. But the purpose of today is to really share with you our findings of a study, which was a small-scale study, looking at exploring the stress and coping experiences of staff working in care homes during COVID. Or some might say, as the image portrays here, opening Pandora's box. So I think at the start of COVID, of course, we began to realise some of the challenges, but we really had no idea at that point what staff were really experiencing and the level of that impact. I'm not going to talk through all that because I'm sure many of you will know the context, but just a little bit of background to set the scene. You'll all be aware of the context and the real challenges that care home staff faced during COVID, in particular things like trying to implement social distancing with people with cognitive impairments, for example. And of course, the negative media portrayal that was often there. So those two red titles have actually been taken from media articles at the time. So it was a very challenging backdrop, as we know. So at the time, what was the evidence and what was the gaps? And as we can see here, unsurprisingly, there was lots of evidence in the literature to suggest that staff are or could be adversely affected during pandemics, other pandemics that had happened historically. And lots of the studies at the time were quantitative. There was a qualitative study there, but that was in Spain. And some of the other studies were more around acute hospital care as opposed to a care home context. So that left us with a bit of a gap. At the time of the idea, we had no money, so we had no funding, and our university had a bit of a dragon's den pitch for very small pots of £10,000. So we put this pitch together and won one of the pitches to do the study. So it is kind of, smaller in terms of scale of some of the other studies. So this was our aim, to explore stress and coping and the experiences of staff. We data collected between January and May 2021. And what did we do? So we worked with an organisation called Balhousie Care Group, who many of you will know. They have 26 care homes across Scotland. Why did we work with them? Well, it was a little bit of serendipity. At the time, I had a colleague who was actually delivering some teaching for this care home organisation, and I'd been asked to help. And of course, you start to build relationships with people, which always makes research a little bit easier. And of course, we wanted to do something quickly. So that's why we worked with them. We put out an online survey, which really had demographic data around what their job role was, some of the work-based characteristics, and we used 2 validated instruments of stress and coping. And then at the end of that, there was an opportunity to then people to say they wanted to participate in an online interview. So, of course, we did some descriptive statistics with that, and then the main piece of work, given the numbers, was around the thematic analysis of the qualitative data. So, what did we find? Well, we only got 52 participants for the survey. Balhousie actually have a staff group of around 900 staff. At the time of the study, they felt that there was about 450 staff that were on the books and available because they had that many people off sick or shielding or other reasons of absence. So that was their kind of population as such. As you can see, age was fairly well distributed across the data. If we look at things like gender, roughly 90% were female, so that kind of fits the workforce demographic. And here we had quite a large number of managers participated, and what we ended up doing was almost all managers that work for Balhousie are also nurses. So we did kind of group that data together. So when we do that, we've got roughly 45% nurses and 55% carers. And of course, this doesn't represent the staff portfolio in most care homes. It's usually about a 1 to 10 ratio. So just to be mindful of that. Quite interesting, over a quarter, so around 27% had their own health issues. And of those, 19% reported a mental health issue. So we know in the literature that people with existing mental health problems often are more at risk of stress expanding into distress and other psychological impacts. So that was quite important. And then, of course, we could see that 50% had caring duties, and that adds to our additional daily stresses, usually. I can say that as a parent. And as we can see here, the stress score, unsurprisingly, was high. So the mean score here is 38.7, and anything between 38 and 56 is considered high at the high end of the scale. But actually, their coping skills were medium to high. So this wasn't about this particular group that the care home staff couldn't cope. In fact, they had good coping skills. They were stressed, obviously, due to what was going on. So what was going on? Well, here is our kind of qualitative analysis. And we looked at that in two groupings, one for stress and one for coping. And we've created these kind of visual schematic things to try and represent what the sort of things were that came across. And I'm sure people can see there's probably no surprises in there. So lots of kind of personal influences. And we'll look at an example of that when we look at a personal sacrifice. Changed care environment, and of course, care homes became, as staff told me, very clinical. We had to remove lots of personal things. The fact that people had to wear PPE felt really depersonalised in terms of providing care. So all of that contributed to staff stress. And there's lots in there. I won't. Amplified scrutiny was also a big thing. So people felt like they were really being judged, and that actually that scrutiny was not always helpful. So people told us things like, you know, we've been working all these extra shifts, we're absolutely exhausted, we're short-staffed, and yet somebody's just told me off for having the wrong version of a poster on display. And actually that's really not helpful. So, you know, that came across really quite strongly. And of course, there's lots of psychological responses that they shared with us. Most of our participants were distressed during interview, and for some of them, it was the first opportunity they'd had to actually stop and think. And some of them were actually surprised that they were distressed during that interview. But of course, as they started to share their experiences, they started to realise just the full impact that this had had on them. So this is just one small example, but what came across really strongly in the data was this notion of personal sacrifices. Now, this is not unusual in nursing and the healthcare workforce. People tend to go the extra mile as the type of people that are attracted to the job. But what was, I guess, more surprising here was the degree of that self-sacrifice. I mean, people moved out of their own homes. People sent their children to live with relatives. You know, a pretty extreme self-sacrifice just to try and keep the residents safe and continue to go to work. I'll just let you read that. So, unsurprisingly then, this had a big psychological response for staff. I'll let you read that as well. So as we can see there, some of that stress was for certain leading to distress for some of these participants. And we did give onward support in terms of them accessing a support helpline and so on after these interviews. But there was also some good news. There was lots of real positive things around what enabled them to cope during these really difficult times. And as you can see there, personal factors, so things like people's disposition, having an optimistic outlook, sharing things like humour seemed to be quite a big thing amongst staff, just to sort of keep themselves going, and lots of other things there. People started to establish things like daily habits and routines. So, you know, I'd finish the shift and then I would go for a walk for 10 minutes just to clear my head, or I'd walk home and things like that, just to try and improve their general well-being and coping skills. Leadership came across really strong, and we all know how important that is in the workplace. But what was described to us was a real open and authentic leadership. So they really believed that although it was difficult, their managers and leaders at all levels in the organisation were really attempting to support them in whatever way they could. And importantly, things like teamwork, which we know is a huge thing. And then at the bottom, we've got safety and security. And this was things like when things started to settle. So actually, this was the protocol, and it stayed fixed for a period of time, whereas before of that, this constant change was creating lots of stress. Things like PPE, vaccinations, and all of that were adding to provide some security during these difficult times. And all of that was really built on relational interactions, whether that was with their colleagues, families, friends, and even residents. You know, all of that was about, this is what helped me cope and who helped me cope. So just picking out one aspect of coping then, and you'll be familiar with how important teamwork is, but there was a real sense of family among care home staff that spoke to us. And this was not only with the residents, so they viewed the residents often as their family, but also between each other. They went above and beyond normal support, supporting each other through really difficult times. And I'll just let you read some of those quotations there. Okay, in the interest of time, I'll move on. So what were the limitations? Well, of course, one organisation could be one perspective. We don't know if this is representative of what other people were experiencing, but certainly having spoken to some staff and some feedback we've had on social media and so on, tells me that the findings seem to resonate with people that have worked across the sector at that time. I guess our biggest limitation is our sample size. So we have no idea that the people that really came forward are representative of the care home population as a whole. And of course, recruitment was incredibly challenging during COVID, as I'm sure others have experienced. We did lots of things to aid recruitment. So we had people didn't have their own email accounts linked to the organisation. So recruitment was, that was my initial recruitment idea that fell flat on its face. But they did have a newsletter that everybody read, so we embedded a QR code into that newsletter. As the image is shown here, this was the little visual hand dispensing units that they had in the care homes, and they had a sort of VDU display unit. I created a couple of minute video, that's me outside in the snow in the Highlands, freezing, trying to do a recording at social distancing, trying to sort of tell people what the study was about and if they had an interest in participating. So we displayed them on there. On their iPads, you know, we had the sort of direct link to the survey and things like that. So we really did as much as we could, but recruitment was still challenging for obvious reasons, that actually these staff were pretty overworked and there wasn't a lot of time. So where next? Well, we'd really like to take that data and think, well, what do we do with it? What are the next steps in terms of supporting them? And initial ideas have been around designing or co-designing a well-being intervention. But actually, this is where it would be good to speak to people today, because you know, we don't want to do something that just scratches the surface. We know that actually these are a population of people that have pretty good coping skills. So what else is there in that data that we can actually act on? And it would be interesting to see what people are saying today. And I noticed there was a poster, so I'll try and speak to somebody about a wellbeing pathway that would be of interest. That's the team. I didn't have them all up at the start, but people all just chipped in and helped. We used our small amount of money to recruit an RE a couple of days. That's the QR code if we're sharing the slides, if anybody wants to read our publication. And that's it. Any questions? We've got lots of...
Hi. Hello. Right. I think we are having to forgo the questions on Slido And I'm now welcoming, is this Charis? Caris, sorry. Caris Marek is coming up to talk now. So thank you, Caris.
Yes. Go ahead. Sorry. Sorry. So I'm really delighted to introduce Caris Marek, who's going to talk to you just a wee second, just while you're going through this first session, which isn't what you expected. Just reflect a little bit about how you're dealing with that uncertainty and thinking a little bit about how that relates to what you think research is, what your perceptions of research were, what these talks are showing you about the different kinds of research that there are, and then after Caris, Maria's going to tell you a little bit about that and see if it comes with what you expect. So do be thinking about your own questions and experience of different types of research, because you're getting a really broad introduction to different things in an unexpected way this morning. So thank you very much for your patience with our technical issues and our making our best of the situation, which I think that last talk just reflected how you've been doing that for the last few years as well. Thanks very much, Karen.
Thank you. Thank you for the introduction and for the chance to speak today. It's great to be back talking to people in person. So lovely to see everyone here. So I'm going to try and give an overview of over 4 years of work in 15 minutes. So it's going to be very high level, quite fast paced, but I hope I give you an introduction and a flavour. We'll do some more in the workshop this afternoon, and also I'm willing to speak to anyone anytime about any of the ARCH project. So ARCH stands for Antibiotic Research in Care Homes. The longer title is Understanding and Improving Antibiotic Prescribing in Care Homes, a Multidisciplinary Approach. So the sort of background to this work is the recognition that the way we use antibiotics contributes to antibiotic resistance, which is an increasing global public health problem. There's been lots of work looking at how we might improve the way we use antibiotics, but it's mostly focused in hospitals and in primary care. But care homes are a very unique environment, which is separate from any of these. And residents in care homes, they receive a lot of antibiotics, but they're also at risk of of side effects of antibiotics, and including antibiotic resistance, but not limited to that. But they're also a vulnerable population that need a lot of antibiotics, and knowing when to use them and how to use them is not straightforward at all. So we wanted to work with people in care homes to try and understand the context and how antibiotics are used, and how we might work with people in the sector to improve antibiotic use. It was a multidisciplinary, multi-institution, multi-investigator study. You can see the rogues gallery across the bottom there. And we had a lot of engagement from people in the care home sector, both people working directly in care homes, also groups like Scottish Care and Balhousie Care Group were involved in our study advisory group and gave us advice as we went along. So there were 4 main work packages. The first 3, we were gathering and looking at empirical data and then pulling that together and co-designing with stakeholders an intervention to try and improve the way we use antibiotics. Important to think about the other influencers on what we did. I've said stakeholders. We had a broad study team and a study advisory group. And we also have to acknowledge the impact of COVID-19 on this work. So this wasn't about COVID. We started in 2017. But obviously, there were major changes in what we did and how we did it due to the pandemic. So I'm grateful to Jenny for giving an introduction to how we use routinely collected data. So this study was based in Tayside and Fife, and we've done a lot of work locally to improve the data, similar to what Jenny had done on a national scale, but in Tayside and Fife, to be able to identify people in care homes and which care home they lived in, but to do this in an anonymised and secure way. And we did this to look at patterns of antibiotic prescribing and antibiotic resistance in care homes in these regions. So very high level, there was 148 care homes included. It was care homes for older people specifically. Most of them were privately owned. Residents were obviously elderly, and the majority were female. And most of them used multiple GP practices. So there's very little of like one GP practice serving all the residents in one care home. So there was a real sort of cross, I don't know how to say it, but really a mixture of models of care and relationships between care homes and GP practices. There were 4,500 residents at any one point in time, although people moved in and out through the study year. There was a lot of recorded dementia in the data sets we used, but there was relatively low levels of recorded of other specific medical conditions, although frailty wasn't well measured in these data sets. So the bar chart at the bottom, each bar is a care home, and the height is the rate of antibiotic use over the study year. The two different colours are the two different health boards. So you can see there's huge variation, and this is adjusted for the size of the care home, so the number of residents, but for no other factors at this level. So the highest prescribing care homes prescribe 10 times as many antibiotics as the lowest prescriber. And there's a whole lot kind of in the middle. And once we looked at the factors that affected the likelihood of having an antibiotic prescription, the care home a resident lived in was more important than the GP practice that resident was registered with. And that just really reflects the importance of the care home in looking at how we use antibiotics. So we then went and did 2 work packages which used social sciences to really understand the context and what was going on. And this was a smaller number of care homes that were selected based on characteristics from the big data. We had a researcher spent a lot of time in the care homes working with staff, looking at things like why do people do what they do, and how does the context, the social culture, influence those things. Who's involved in antibiotic use and the actions that lead up to antibiotic use, and what would be the key moments to intervene and improve things, but also what are the good practices that we can build on and share. So there were 7 care homes involved in this part of the study. We originally aimed to do 8, but as COVID was kicking off, we'd finished 7 and we had mountains and mountains of data already. So we stopped data collection at that point. We did over 100 interviews. I say we. Jane Dixon was the main researcher who worked on this. Some of you may even have met her if your care home participated. She did 61 periods of observation, and we also did surveys, but they were sent out electronically to a much larger group of care homes. And this was over nearly 2 years, all this work. And we did interviews with everyone from the managers to residents and residents' relatives, and also GPs and ANPs and pharmacists who worked with the care homes. So a huge data set that we're still getting to grips with. So one of the key findings was that, so we think about antibiotic prescribing, and in initial work, people in care homes thought, well, I don't prescribe the antibiotics, it's nothing to do with me. Well, not nothing to do with me, but they didn't feel responsible or ownership or didn't feel they had a role in it. But it's actually the end point of a process which does involve a lot of really skilled but underappreciated work by care home staff. And one thing that the behavioural psychology team within the study, one model they use is to understand and influence behaviour, you have to give people the capability, the opportunity and the motivation. So any intervention to improve things has to address those 3 things to then influence behaviour. So we pulled together all the findings from those 3 work packages and looked at obviously what else was going on in the published literature. We held a co-design workshop with 20 key stakeholder participants. We also included residents and residents' relatives in that co-design workshop. And we came up with an intervention package which consisted of tools, which we'll look at in more detail in the workshops, supported by antibiotic champions within each of the care homes, training, which included a video. You can see stills from that in the top corner. We had a couple of very good care home staff members who came and helped us make a training video, and some packs of information. We called them GP ANP packs of sort of background supporting information, but those were also provided to the care homes who participated in the testing of this package. So this is where COVID, while we were designing the intervention package, it felt like COVID was sort of not going away, but numbers were coming down, and the vaccinations were rolled out, and people were supportive of us going on with the testing of this, but the testing was limited severely by COVID. We aimed for 4 care homes to test this over 6 months, but 2 care homes managed to test it for a good period of months, and two that initially signed up for it were not able to do the work, and we completely understand that. So we did some additional focus groups and interviews to get a bit more input on the study, and just kind of putting into context the findings here, the staff shortages, I don't need to tell anyone in this room, following on from COVID and ongoing still, were really impacted on what we're able to do for obvious reasons. So that was just an overview of what we did and how we did it. I'm going to give some very brief sort of findings in terms of what the impact of what we've found might have on practice, both in terms of implementing interventions and even just other new ways of working. So thinking about antibiotic stewardship, which is about improving the way we use antibiotics, there was always a balance between people saying we want things that are the same across all care homes so that we reduces the need for extra training and makes things consistent. But then also people said, well, our context is a bit different. We do things a bit differently. So how much do you allow tailoring for individual settings, but still some standardisation? Empowering carers to use their skills, but feel supported in doing so. Because we felt there was a lot of concern about doing the right thing, and it feels like when someone's not well, giving an antibiotic might be the right thing to do, and feels at that moment in time perhaps the safest thing to do. But when you think about potential side effects, potential future resistant infections that are then harder to treat, is it the safest thing to do? And it's not straightforward. But I think empowering people to make the decisions but not feel blamed if things don't go quite according to plan. Again, I've said it's a really important role around antibiotic use by care home staff. And we do also need to think about very specific things. So urine dipsticks are no longer recommended in care homes, but there was still wide use of urine dipsticks in the diagnosis of urinary tract infections. So there are very specific things to address, but there are also very high-level things about empowerment and support to have a more active role in decision-making. And there's some overlap here in some of the topics, but in engaging the workforce, we don't want to feel like you're just giving people extra things to do. You want to kind of try and show how it will benefit the team more broadly, as well as improving that specific thing that you're trying to target. And again, I've mentioned about the worry of missing something and giving an antibiotic to avoid missing something that you could potentially feel like you might treat. But we did find that the variation in antibiotic use that couldn't be justified by the resident characteristics does suggest there could be room for reducing antibiotics. But we're not only talking about reduction, we're talking about improving. But they are used more than needed, but it's, as I say, it's not straightforward and not easy. And I think the sort of blame culture that COVID has probably exacerbated, we just need to kind of support and address that and support staff retention and recruitment. But that's not nothing specific to the ARCH project. That's just care home life. But one way of addressing this sort of problem is taking a very systems approach, and you need to do that. You need to engage and work with stakeholders at all levels, from individual people up to the big organisational levels, including sort of up to care inspectorate, government policymakers, down to the people who are working on the ground in the care home day to day. And understand the sort of interactions and relationships between these different organisations and influences within the system, things like time for training and building anything you're trying to do into existing training requirements. Thanks, Leslie. One thing we found as well, and this is what we really need to harness in anything we're trying to do, we found a really caring, dedicated workforce who really want to do the best for the residents and make improvements. They don't want to just carry on doing what they're doing. They want to make improvements and engage with things, but just finding the time and the support to do that was the problem, really. We also found them very adaptive to change. I mean, so many changes during COVID. People took it on and worked with it and really got on with it. And that's the kind of enthusiasm and adaptability that we need to harness. And then we need to fit this into the ways people work already and training and new staff members. And again, trying to avoid any additional burden. And there's differences between when something gets rolled out into practice normally, and whenever we do research, there's usually some extra work as well. So we need to try and think as researchers how to reduce that additional burden, but to be able to test new things in a rigorous way in care homes. So I hope I've given you a flavour. It's been a bit of a whistle-stop tour of a huge piece of work. Please, as I say, ask me any questions. We'll look at the intervention tools in more detail in the workshop and talk about sort of implementing change in practice. And I just want to say thank you to everyone who's supported and worked in the study, particularly the participants, and to you for listening. I think that's exactly 15 minutes.
I think next we're having Maria Drummond, who is our full-time person working in ENRICH. Just as Maria is going up to the podium, could people who are here from care homes put their hands up, please? Great. What about researchers? NHS? Okay. And care staff from social work. Any social work care staff? No. Just wondering who the audience is. Who have I missed? Oh, university staff. Well, that's mostly researchers, isn't it? Yeah. Okay, thank you. That's great. Lots of care home people here, so thank you.
Just taking that wee minute to see if this will reattach itself once I plug it back in again. You didn't want to see my emails. No, why is that not working?
So if you can come out of that and go back in, it should recognise there's a second display. Oh, no, it was, it's set to 2 screens, so you'll have to drag it across if it's not in her white logo.
Oh God, where did I do that?
Hi. Hi. My name is Maria Drummond and I'm the Senior Clinical Studies Officer at ENRICH Scotland. So this was going to be the start of the day, just to kind of set the scene for what's to come, but hopefully what's included in it will help us to reflect back on what we've already heard today. So I'm just going to discuss what research is and start by discussing what research isn't. And the reason for that is that sometimes there can be a bit of mystery about what research is and a bit of confusion about how it sits alongside other processes. And I think most of the people in the audience today are from health and social care, and we're probably quite familiar with audits, quality improvement and service evaluation. And these processes are quite distinct processes that are about understanding what happens in the real world, matching what's happening with specific recommendations or guidelines, and when it comes to quality improvement, taking that understanding forward and aiming to improve things. I've also put Googling up there because I think during the pandemic we've heard lots of people talk about how they've done their research and they maybe understand specific treatments or maybe vaccines or what's happening in the world. But what they often mean is done lots of background reading and tried to get to grips with a subject. And these processes are all really important and can often inform future research, but they are distinct from research. So this is the definition that we work with at ENRICH, which is long and boring. You don't really need to worry about it. But if you can kind of get your head around the first sentence, then you've got a good understanding of what research is. So the purpose of research is to create new knowledge. And we create that new knowledge by answering a question. That question could be a totally new question, or it could be an existing question that's answered in a new way. And we do that through scientifically sound methods. So, so research can be about improving things, making treatments better, testing new interventions, new ways of working, but sometimes it's just about understanding things that we don't really know very much about. So there's two kind of main camps of research. We've got the qualitative camp and the quantitative camp, and the reason that and the way that they kind of are different is the type of data that they work with. So qualitative data collects words as data, and quantitative data collects numbers as data. But increasingly there's an understanding, and we've already heard of some examples today, that the world's complicated and we can't really just rely on numbers. So quite often studies that are quantitative are now mixing and qualitative methods to really understand what's happening and how people experience the things that's been tested. So since we had funding from the Chief Scientist Office, we've worked with loads of different research teams, and these are just some examples of the types of studies that have happened in care homes in the last 18 months. So we've had teams that have tested new physical activities for residents, we've had interviews with staff about spiritual care, there's been a survey on digital connectivity, and there was even plans to test new COVID-19 drugs. Because of the success of the vaccines, that didn't need to that kind of didn't really go beyond the kind of planning stages. So to really demonstrate that, because research in care homes has been overlooked previously in the past, but can really be done on anything. There's even been some studies on what it's like to participate in research for care staff. And that research has told us that there's a number of challenges and there's a number of benefits, but ultimately the benefits outweigh the challenges. And the reason that ENRICH Scotland exists is because we want to try and help care home staff, residents and relatives to overcome those challenges so that benefits can be maximised and experienced by the most amount of people possible. So an example of a recent study that's been developed in collaboration with ENRICH Scotland and Edinburgh Napier University is a study that came about during meetings that we were having with care home managers. One of the managers just said, you know, if you're looking for something to research, then go and find out why I can't keep any staff. And from that, we generated a research question. And the hope is that we can interview care workers and care home managers about intention to leave. So understanding if you're thinking about looking for a new job, or you're a care manager, what your role is in supporting staff who are thinking about leaving, staff retention and recruitment, and hopefully we can create that new knowledge and we can take it back to care homes and say, what can we do to try and improve staff wellbeing and improve staff retention? So this study is currently recruiting the recruitment's open for about another week, but we can do interviews into November. So if you are a care worker or a care manager, you've not participated already and you work in Edinburgh or Lothian, you can approach one of the ENRICH Scotland team and they'll point you towards me, and hopefully we can arrange a short interview between half an hour and an hour. And that's me. Thanks.
Thank you, Maria. I'd like to welcome Luis Suarez. Are you here?
And as Lewis makes his way down to the
Great.
front,
Thank you.
just a reminder for you all, if you managed to log in, who managed to log into Slido? Excellent. If not, we'll do a wee reminder of how to do that, and you can put your questions, any comments in the chat, and also your questions about the question that we've put to you to answer. You can see what everybody else has put as soon as you put your response into that. It's just a wee reminder about the Slido. Emma.
So Slido, you go to Google and you find Slido, and then you put in the code, which I'll repeat, 32533423.
Yes.
I'll repeat the code again, 32533423. Thank you.
Okay, that's me. Thank you and good morning to you all. Hope you are not too tired by now after these 3-4 amazing presentations. Really interesting, all of them. And just to let you know that this is not my natural habitat. I don't feel very comfortable here. And it is the moment where I expect that my English could be at the best of the best, but it really plays an amazing trick, and my brain decides always to run to my native language, which is Portuguese, and therefore make my accent to become, sound like French, something like that. And honestly, I'm trying not to panic and to deliver and to show you a little bit of what we have been doing in an amazing research which speak a lot to me. I'm really keen and have been always keen in trying to tackle different forms of ageism in our society. It comes in a different ways. It's horrible. The culture where I came from, the elder is really appreciated in the society. He has a place. We aim to be a elder. I'm aiming to be an elder and back home and to deliver everything that I have experienced through life to deliver to the next generation. We don't ask people the age, how old are you? It's rude. It's not relevant. The important is not what the age do for you. It is what you are able to do with the age you have. And the more you live, the more you will be able to do, because from an hermeneutical point of view, the more you know about the world, you will be always able to have a kind of interesting solution for something, a word to share and to help people. And therefore, this is why this research speaks a lot to me. So the research, my presentation, which is not original mine because I'm covering for someone that was meant to be here, who, an amazing person that I work directly with, but unfortunately Sarah could not make this morning, so here I am. So the presentation will cover this aspect. So we're going to go through the project info, the project aims, our methods, the engagement that we have obtained so far with care homes. I will be talking about the Ripple framework, which was something that my team, me myself directly, we developed to create forms of obtaining meaningful engagement with the care workers, and key message and findings that we are able to generate so far. We are not halfway of the research. We are approaching, so it will stand until Feb 24, so we should be near halfway. And the likely directions that the research might take. Next. Here we go. So the research has a lot of different partners. From the academia, we are the two, King's College, who run the project, and Edinburgh, so we run the project. But we have other partners that work with us, namely the Code Base and the Creative Venue, and these ones are the ones that are working hard to identify trailblazer community innovators, entrepreneurs that are doing amazing pieces of technology, developing service and new solutions that could be brought into the care home environment and help the care worker to have a better way of doing things. This project aims basically to cover two critical aspects of the care homes that we have identified, which is the retention and also recruitment and retention. So according with the patterns and where we see, it's around time for us to intervene. Because if we don't intervene right now, care workers, which majority is above 50 years old, females, if we don't tackle those that are working now, in 15 years' time when they reach the retirement age, maybe the care sector will be in a state where probably will not be able to deliver something that they have delivered in the past, so they will not be able to receive these. And these are the two aspects that this research is trying to tackle, trying to find ways, and we are doing this through co-design and trying to learn from the care workers which one are the key constraints and listen from there. So this is very much a bottom-up approach. So we learn from them what is the struggles. We design with them the solution that might help them to overcome those situations. We are not expecting to come with solutions that might address the industry kind of cross, one solution fits all, is not what we are looking. We are looking in a very specific contextual way what can work for this particular care home, and probably will have potential to sort out, to be fixed in a different context. But by this I mean that we are not trying to find one hat that will fit all of you. No, definitely not. But we are trying to find as much hats as possible so we can try to address solution. And this will come from the care industry for sure. So this project was founded by the ESRC. It is a large sum, but the large sum also indicates the importance that they have given to this research. And moving on, and okay, should we here? Yeah, here we go. All right. That character there is trying to already to illustrate some of the concerns. And this is a big worry, mainly in present times where the energy crisis, which came out of a situation that was not expected, this sad war between Ukraine and Russia, which has affected not only the UK, but has affected Europe and all of the world, and is having a massive impact into the care sector. And I hope that things could change direction in the next few months when the market start to become a little bit more stable, that energy crisis could be addressed, not solved, but addressed, and that this does not impact too much the care sector, the care homes, the residents, the staff that work there with the next winter come. That is, in fact, a big worry. Okay, so by this I want to emphasize that our key goals are these. I'm not going to read the slide. I will leave you to read. But our major concern it is how we can create a better working environment for the care workers. This is, in fact, our main concern. And we are doing this through co-design process. I don't know how familiar you are with co-design process. Maria spoke a little bit ago about the big divide in social science and between the quantitative and the qualitative. So the co-design lives within this qualitative side of it. We are not trying to measure how much, how big, all these things. No, we are trying to go deep and understand what is really affecting these people. And this could not be done, that is not by listening to them, to engage with them, and to get the hands dirty, put them to do things. We have one of our methods today down there, and I'm expecting that some of you could engage with us in this activity. It's called the Circle of Care. Later on in the presentation, you will see it. We have an amazing gift for you as a souvenir, a pair of AirPods, a kind of a trade. Okay, I think that is always good. Me, I'm a social scientist, and I have background in communications and in science and technology. And the way I like to do research is not from an extractive point of view. It's not to go there in the world and to grab a big amount of data, qualitative or quantitative, and come and sit and do things and put inputs out there. It's not the way I operate. It's not the way I think that the academia also should operate exclusively. I think that more than to extract, we need to deliver. And more than outputs, we need to generate outcomes. That is what makes the difference. That is where the interventions start to be meaningful for all of us, and it's where we start to work in creating a better society. This is a new trend, but this is also part of my mission, not only to tackle ageism, but through research to try to make a society a little bit better. Moving forward, so our project rely on two methods. The first one is ethnography, which means that one of us will go to the care home. We started by doing something that we call deep hanging about or walking around, depending on the perspective. Just looking, talking to the people, making people aware that we are here, okay, because we don't aim to be invisible. We are here. We are working with you. Can you talk with us? Tell us what is going on, why you do that in that way. Have you considered eventually this, that would make difference, and etc. And we engage and we obtain data. And this data, this information that comes help us in the next stage to define which one could be the best strategy to then start to unlock. It could be the Pandora box, but we will be there all together as a team to face the opening of the Pandora box and to fix the problem. And this is where the co-design starts to operate. So far we have delivered from our method matrix made of, also it will be there down there if you want to see our method matrix, which is made of 30 methods that can point us to different ways of doing things. It could be to create, it could be to assess, it could be to re-evaluate the service, the journey, all these kind of things. So we have plenty of methods that allow us to never get stuck in any context where we are immersed doing research. So far we have used some design probes. So we sent out a poster which has introduced four trailblazers which has been doing things in the context of the COVID. We had people delivering gymnastic classes online. We introduced to them how this could be useful for you in the future. We introduced Peggy, which came up with an interface where now a lot of tasks and procedures that go in the day-to-day of the care worker, which push them to have a lot of paperwork to do daily, and take them out of the core that is to deliver care. So this PEG came up with a solution where all these plans, activity things are all in one, and these not only make it easier to have all the information in one point, but also really quickly to introduce and to disseminate. So I can just go and measure the temperature of one of the residents and I can input there, so my next colleague will know that it's done because he will be informed. And this eventually is increasing the speed of the process. And I have 2 minutes, which now is time probably to rush. Okay, so this is our research timeline. We are expecting to reach Feb 23 with most of the care homes, the work with the care homes done. We are expecting to engage with up to 6 care homes and 2 retirement villages in England, which have been already identified. So then we will have 2 different contexts to compare eventually, how things work. And each of the care homes will have 5 points of contacts, 5 co-design sessions, and each of the co-design sessions has a specific target. The last one is futuring. We expect that after we have done 4, we will be able to have identified which one are the key issues, the key constraints, and therefore we start working futuring. After that, then we will bring into the scene the trailblazer community, the best match, and then these 2 will move towards something that we want to introduce, that is a new entrepreneurial form of delivering care service and to deliver care. And then these 2 will start a new journey that now that we have identified what is going on here, which one maybe be the best form of tackle this. Now you work with this trailblazer community that has already a service, a product, something that is closer, and then they will tweak this thing and make this thing to eventually fix the problem and in the future to be escalated across other care homes. Okay, so this is the circle of care. It is something that we collect from a method that has been all out there. We redesign and we deliver. We have tested. It's great because it shows that care is not only made of one thing. It has a lot of different components, and as a bike wheel, you see, if we remove one of the spike. If we spoke, yeah, that's it. If we remove one of them, the thing might go funny, and 2, wow. So, which means that care is made of all these things, and all of them need to be present in a more holistic perspective. And I really invite you, not only because of the nice AirPods, but to go and to try it, okay? We have the iPad there. He has a very short film. You will see the film, and then you can engage with the activity, okay? That image there, it is a bespoke co-design path that has been designed for one of the care homes, and that is all the engagements, and each of the stage of the engagement, it is aiming for something different, always trying to obtain what we call this meaningful interaction with the care home. These are some of the examples of the trailblazers community that we have introduced. We are not trying to sell service. We are not trying. It's just to give them highlights what has been done and what works, and departing from there and see how this can be adapted to their own context. And to finish, say that I think I already covered this. So we are already focused and identified that we might be working in a little bit of digital transition, that is to remove the paperwork out of there and to bring things that people can touch as they go along in their day-to-day and to do things. It might be one of the transformation that we will have to go through. Also, we have seen that there is chance for a new entrepreneurial roles. Because if people learn about the co-design process, which is what we are trying to do, we are trying to train them to be co-designers. And once they have become co-designers, they will be able to understand at any moment what needs to be done, what needs to be changed, and therefore to intervene. And this eventually will give opportunity for themselves in a professional point of view to have a continuity in improving what they do and how they do it. And thank you for listening. This is us. We have our contact there. If anyone is interested to know a little bit more about the healthier working lives, please use this email address. We have the website there. And we will be downstairs with our circle of care, so you can interact with us. And I hope it was clear, and thank you for listening to me.
Thank you, Lewis. Now, tea and coffee are being served up in the top of the room. Yes, up there. And if you could be back in your seats by 11:30, please. And I think we're back on track. Thank you.
In the marquee, a lot of interactive research things going on that you can take part in to see what taking part in research is really all about. So without further ado, welcome back to the pre-lunch session, and I'm really delighted to welcome Jane Douglas, who's going to talk to us about the enigma of social care nursing. Thanks, Jane.
Thank you. Good morning, everybody. Apologies, I should have been on this morning, but I was late, forgetting what the traffic is like in Edinburgh. So I work for Scottish Care as a Transforming Nursing Lead, and I'm going to speak to you today. I've called this the enigma of social care nursing. So in May, we published some research, following some research that we'd completed, hearing the nursing voice, listening to independent sector social care nurses. And the aim was to uncover aspects of the nursing role, the positives and the challenges that nurses experience within the sector. I will also consider some of the thoughts for the future in regard to nursing. The aim of the study was to capture the experience of our nurses who work in social care, to hear their voice and their truth, to help define the role by what they tell us, and to improve the image and promote the value that nurses bring. I interviewed 16 nurses face-to-face, and we also had a focus group at the Scottish Care Home Conference, and we also did a couple of Twitter campaigns, hashtag 3 little words, and hashtag I am a care home nurse because, which helped us increase the reach and the information. And sorry if you hear me crackling around, but I haven't got it on my slides. Invisible and undervalued. Historically, nursing in social care has been an enigma, sometimes invisible, often misunderstood and undervalued. For those of us who work in care homes with nurses, and for those of us who work in care homes without nurses, we will all have our own view on what nurses do, whether they are needed, and what does it mean when we talk about nursing care. So nursing in care homes is a confusing landscape, and we often hear, many people have an opinion on this, and we often hear people saying, what do we mean by nursing care? Why do we need nurses in care homes? Do we actually need nurses in care homes? What do they do in care homes? And it is confusing for many reasons. So, for instance, social work are responsible for assessing nursing needs. They are the decision maker, so while they'll gather information about a person who's needing care and support, they will make that decision on the basis of the assessment that they complete. And I used to work in social work, and I would be the decision maker on whether I would fund based on that assessment. Is that right? Is it right that non-nurses are assessing nursing needs? We also have care homes with nurses, and we have care homes without nurses who are supported by district nurses. And this adds further into the confusion of what we mean when we talk about nursing and care. Nursing is more than tasks. We find it really difficult as nurses to describe what we do, and often we resort to a definition which is based around the tasks that we do, such as medication administration, catheterization, wounds, dressings, that kind of thing. But nursing is so much more than that. Nursing is about being nurse-led, and we rarely talk about these nurse-led models of care, holistic and person-centred, complex care management, coordinating that person's care, risk assessing, and the autonomous decision-making that goes along with that. But I would also point out that having worked in social work, when you don't have a nurse, that's when you know the benefit of a nurse. When you take a nurse away from a care home, you will notice the value that that nurse brings. One of the findings in the research was perception. Social care nurses, not seen, not heard. The images here portray the drama that we see on television. We've got ER, Holby City, and a Casualty. But we don't have a programme like that around care homes or social care. We never have, and those that we did have were quite derogatory, like one foot in the grave. So I think it's important that we change this image, because if we ask the public, they would understand the image of a nurse in an acute healthcare setting, but would they understand what a nurse does in a care home or in a social care setting? And the media then plays into this negative image and further perpetuates the stigma. Is it time for the story to be told through drama? How do we get that visibility if we don't have anything on the television that tells us what we do? Because the role is not understood, nurses working in the sector said that they feel extremely undervalued. And in order to change the perception, one nurse interviewed said, if the public had an awareness of what we actually do, then it would improve the perception of nursing in care homes. But how can we change the perception of nursing and social care? How do we change the narrative? So a good discussion is to have about nurse training. Maybe we should flip it. At the moment, pre-registration nurse training takes place in acute sector hospitals, mostly, with secondments and practice experience out into care homes or in community settings. But we have an ageing population, and we have an aim to support people to live at home for as long as they can in homely settings, of which care homes are. So perhaps we should have our nurse training embedded in the community, including care homes, and so they go on placement into the acute sector. If we really, really want to manage the care and support of older people better, then we need those foundations in the community. It's a big question, but it's worth a discussion. And what about Netflix? We can get back to the drama, perhaps a real modern-day television series centred around living as an older person in a care home might help with the perception of nursing and social care, but also with the perception of care homes. We know that Call the Midwife really increased the numbers of applicants to midwifery. I remember speaking to some school leavers, and they all wanted to be midwives because they'd watched that programme, which, by the way, I didn't watch, but it was very, very popular. So, you know, television series can have an impact on people's decision-making. These were just a few ideas that participants gave through the focus group. Just a care home nurse, I think she might be in the room. So what does that mean? We evidence that stigma is associated with nursing and social care. Nurses who made career choices to work in care homes were frowned upon by their colleagues and their peers, who made negative comments. One nurse said that 15 of her fellow professionals tried to stop her moving to work in a care home. This included a lead for older people nursing. They said, you'll be wasted if you go and work in a care home. And by the way, that's what my charge nurse said to me when I said I was going to work in a care home. You'll be wasted. Others were faced with comments such as, you will lose your skills, you will stagnate. But there are many varieties of nurses. We come in all shapes and sizes with regards to our careers. So just like an apple, there are many different apples, many different varieties, but there's still an apple. We're all part of that nurse family, and we have to respect that, and we make our choices because of the passion that we have. Through the research, we identified the challenges, and to be honest, this will not be of any surprise to anybody in this room, and I was looking at a presentation that I delivered on care homes probably 10 years ago when I was in another role, and these are the same challenges. So it's not new, but it's still there. So while participants shared these positive stories, the overwhelming challenge was staffing. And we know having a consistent team of staff helps to provide excellence in care and improve outcomes for people experiencing care. But participants talked about a constant feeling that they were in crisis with no respite on the horizon. This continued perception and associated stigma about nursing and social care, they felt, stopped people coming to work in the sector and also impacted on retention. So we need to tackle that. Further challenges were having time to care, this to provide oversight, to promote learning and development, and predominantly due to staffing and the current funding climate. Leadership was also key in supporting nurses. Where there was an authoritative top-down approach to leadership, nurses felt that this stifled their innovation and disempowered them, and they were not able to initiate change and support the people that they were working with. And strong leadership was also something that was desired, and nurses expressed that where they felt extremely vulnerable when that leadership wasn't there, when they experienced poor leadership. The overarching aim of the nursing role was identified as ensuring better outcomes for residents, relatives, to ensure equality in life and equality in death. And this is achieved through a holistic, person-centred approach and the 4 principles which are detailed here on this framework. These principles are all interlinked, but the overriding principle was building relationships. Everybody, every nurse that was interviewed and the focus groups talked about that family, the family of the care home, the people that they support, the relationships they build. And without that, they can't do the supporting wellness. They also feel they need to be visible and compassionate leaders, sharing knowledge and empowering others. The value of nursing roles. We identified that the nurses were autonomous practitioners, and autonomy was something that nurses enjoyed about the role. Nurses said the role was dynamic, but it was challenging in a positive and a negative way. nurses said they were accountable and responsible for managing the care and the support and ensuring residents can be as well as they can be. They spoke about the knowledge they required for such a role and having to have that wide and varied knowledge about management of different long-term conditions. But there was that feeling of having to know everything. Nurses explained that they are the responsible and autonomous practitioner. They also said that they help create positive cultures, promote professionalism, and develop person-centered philosophies. They were all able to give examples of their skills and knowledge that they utilised to achieve the overarching aim, which we can see on this word cloud here. And such things like assessment was a very strong theme, managing complex long-term conditions, anticipatory care planning, managing deterioration of residents, rehabilitation, and many, many more skills that are required for this role. So we're transforming roles. Over the last few years, we have seen roles start to change, our nursing roles. And I wanted to talk particularly about the advanced nurse practitioner role. And Erskine organisation have actually developed this advanced nurse practitioner role within their own organisation. And because of this, they have been able to evidence that they have improved consistency in the care and support for people that they are looking after. They've also evidenced that they have save GP time. And some of the research that's been done around this is on this slide here, so you will be able to access it. The role of the advanced nurse practitioner also creates a career pathway for nurses who want to stay in care homes but advance in their career, but remain in a clinical role. So it supports that ability, the right care, right time, right place, right person. But as we see the role of nursing in care homes changing, we have also seen an evolving role for our support workers. These roles are integral to supporting nursing in care homes to ensure consistency and safe care. However, this should be to support nursing, not instead of nursing. So looking to the future, a case for change. The future of nursing role and the model of care will need to change. The pandemic shone a light on our care homes, which stimulated the review of adult social care, which concluded in 2021. There is going to be a national care service. One of the aims of the National Care Service is to ensure that the standard and quality of care given in our care homes is the same standard across all care homes. So the future will be changed, and as we move forward with the creation of the National Care Service, we will have to adapt. Other commitments have also happened since the pandemic, such as the healthcare framework that was just published in June, My Health, My Care, My Home. However, despite all these changes, we have enormous challenges. We don't have enough nurses. The vacancy numbers in the NHS mean that care homes can't compete, and they struggle to. There are more vacancies in the NHS and in care homes than there are newly qualified nurses, so we really don't stand a chance. And we have to change. We need to adapt our models to be fit for the future, so we need to look at new roles and develop the nursing role further. But also, we will need to develop a role that supports our nurses. Say, a para-nursing role. We need to ensure that people moving into care homes have choice about where they live. We can widen that choice if nursing is accessible across all care homes, and that would avoid that confusion. And then if you live in a rural area, you could go to any care home of your choice, not because it's got nurses. The model needs to be designed on the aim, improving equity and the standard across care homes, not the finance that's available, and around the outcomes of the people who need care. So the role will need to develop and adapt and change. And if we continue to do what we've always done, we'll just get the same results. And hence, I'm giving the same presentation practically that I gave 10 years ago. So just to conclude, stigma still exists. We will need to promote a nursing role that we need to promote this nursing role and hear the voice of our nurses. People are living longer and moving to care homes later with more complex care needs. So the nursing role is going to be even more essential as we move forward. It needs to be recognised as a skilled and complex role that promotes holistic person-centred care and supports people to be as well as they can, equality in life and equality in death. However, we will need to adapt and transform our nursing roles and models of care to meet that future need of people who live in our communities, our care home communities. We have this journey ahead of us, but we're not quite there yet. And finally, this is my final thought. Just because we do not have enough nurses doesn't mean we don't need them. Thank you for listening.
Thanks very much, Jane. I think we're listening to your feedback on Slido, so we will have time for a question or two at the end of each presentation this time, I think, rather than waiting to the end. And then if we have time at the end of this session, we'll do some questions from the first session this morning. So just think of your question for Jane. We've got time for one or two in the room, but I also have one on technology from Slido, if I can work the tech. Somebody who hasn't left their name, but I think echoes the feeling in the room, Jane. Do you think there's work to do around changing the perceptions of acute care nurses towards care home nurses?
Yes. Yeah, I think that we have to have that mutual respect for all the roles that we have as nurses. And, you know, I am that care home nurse that couldn't get a job in the NHS, by the way. Not that I'm a bad nurse at all. I'm a very good nurse, and I'm proud to say that. But I worked in Jersey in the Channel Islands, and when I moved back to mainland, I couldn't get a job in the NHS. It was 1995. They weren't recruiting nurses. So I went to work in a care home because I wanted to be part of a team. And when I asked for my reference from the charge nurse in Jersey, she was like, "What? You will be wasted." So I came from an acute background, and I've now worked longer in social care than I ever did work in acute. And my career has been so varied. And I think it's important to sort of share that about we can have different careers as well beyond acute nursing. I think we need to respect acute nurses. They do a great job too. And it's that, but people don't understand what we do in care homes, and that's why we need to get that out there. And at the moment, I've got a questionnaire that nurses in care homes are completing for me, and I've got about 36 respondents, so that's quite good, about what they do and how they see their roles. So I think there is a need, but I think it's about us being a bit more vocal about what we do.
Yep, so today's is part of that, and these presentations will be available afterwards, and we're going to try and distribute them far and wide so you can share this message to everybody else. So if you can think of ways to do that, or if you want to star in Jane's new upcoming TV series about social care nursing. Any questions in the room for Jane? Okay, well, you know where she is, and she's going to be around all day. So, there's one here. Anna.
Hi, yeah, I'm Anna. I'm a PhD student at the University of Edinburgh. I was wondering what you think is the importance of having management in the care home that has nursing background and experience.
Okay, we obviously have care homes that have nurses, that have managers that are not nurses. That sounds really confusing. And we have care homes that have managers who are nurses. Not all nurses make good managers. That, you know, we have to. Some nurses should remain in a clinical career, and I think that's each and every one of us has to consider where our skills are. I think the problem can be, and some of the vulnerability that came through from the people that I interviewed around leadership was where the manager was not a nurse. It's not suggesting that that manager was a bad manager or a bad leader, but I think it was confusing for the nurse, because the nurse has that responsibility. You know, if you're a nurse on duty, you're that autonomous. You've got that accountability and responsibility. So you know there could be tension there. But I also had a manager when I was a director of care homes, and I had a manager who wasn't a nurse, and she was absolutely brilliant. But she also understood the nursing role. So I think it really does depend. I think it's similar in the NHS. They have managers who are not clinicians. I'm not saying whether that works or not, but I think it helps if it's a nurse, but I'm not saying it has to be.
Thanks very much, Jane, and thanks very much for your questions. Any other ones? I'm sure you can approach Jane later on in the day, and as the day progresses, keep these conversations going. Thanks again.
Thank you.
Next up, we've got Cheryl Henderson, who is going to talk to us about CHIP. If we can get the tech to work. So, thank you again to Jane. And again, if you keep your questions coming in on Slido, we can pass those over to the speakers, and they can come back to you with questions, and we can do a summary at the end of the day. We'll send you out an email at the once we've finished with background from the presentations. Thanks very much, Cheryl.
Thank you. Thank you very much for inviting me. And I was one of the managers that decided I wasn't in the right place as a manager. So my role is actually doing dementia development and education within elder homes. But I was asked to come and speak to you about a kind of sub-branch of ENRICH called CHIP. And thinking of the title, Neil very kindly helped me with it, when I told my husband that I was part of a chip group, he was very excited because he thought, egg and chips, fish and chips, because they do like a good acronym, I've discovered, especially in research worlds. But they're really helpful, and they do make a difference. So what does this chip stand for, says she? How do we want to say? Is it just that? Okay. There you go. So you'll see a couple of posters down in the marquee, and this one was brainchilded by Maria. But this is about CHIP episode 1. This is the beginning. Everyone's got to start somewhere. So it says a long time ago in a galaxy far, far away. It wasn't. It was in Edinburgh. But you know, we'll go with that. We had a vision. Now, it was Jo Hockley, who many of you will know, and the vision was for something which she was calling the Training Research-Based Care Home, or TORCH, another acronym. But this one is something that takes on a lot of what Jane's just said and a lot of what other people have said, taking care homes to the next level, having a real centre of excellence to really bump our gums and shout very loudly that what we do is damn good. What you do every single day is so good. It needs to be replicated. We need to get more people involved. We need to do it because this is the future. This is exactly what's going to be happening. This is where I'm going to be. Hopefully not yet, right? But, you know, it's where we all want to be. We want to make sure that we're getting the very best care for people. So in doing this, that was great, but there was also recognition this was not going to happen overnight. This isn't something that's just going to suddenly happen like that, which would be great if it did. So what to do in the meantime? We could twiddle our thumbs, but there was also that thought of, well, actually, what do we do with the time that we have? So Jo had decided that there was a real sense of a missing piece, literally a missing chip, which was the Care Home Innovation Partnership. So this commenced with a group of, I think it was 7 care homes at the time, but also academics, researchers. And the idea was that they would be able to come together regularly and look at things like collaboration. A lot of today is about collaboration. Probably the best learning you'll have is the little chats that you have in between times. No disrespect to any of the speakers. But it's all about sharing. It's all about working what it is. Let's share the best practice. We all do so many good things, but one care home has got a real focus on maybe end-of-life care. Another one's got a real focus on maybe students or using technology. So let's collaborate, but also there's a strength in that support as well. And innovation, I think sometimes we're quite frightened, maybe as nurses or people with care homes, about the future. You know, well, we've kind of done it this way for a while and it works. Yes, it does. But do you know what? There's something better out there. So let's look at innovation. Let's look at developing things. Peer support for anyone is important. The last 3 years, particularly in care home settings, any health setting or social care, but particularly in care homes, that has been invaluable. You've already heard some of the statistics that have come out. Life was pretty sucky for everyone. But when you're on the sharp end of it, trying to support people, looking after people that are actively dying, supporting their family who are in tears because they can't get to see them, supporting your people that are there, you need support yourself. And I think sometimes we forget that. We really need that sort of virtual hug, if you like, of somebody who gets what we're going through, because our colleagues don't because they're not the manager. Our colleagues don't because they're not a carer. The other thing that was very, very clear was tests of change. If you want to be innovative, that's great. Let's go and let's try all these different things at once, and you're just going to fall flat on your face. So testing things a little bit at a time makes such a difference. And the idea was, with the tests of change, that we would try different things. So these are just a few that came out. One was Namaste, thinking about really good holistic support for people at the end of life, particularly living with dementia, where maybe there doesn't seem to be a lot of connection. And this is something that a lot of care homes are taking forward. EMA, again, taking that electronic step into the future with medication. Electronic care planning, again, the same thing, but looking at that, which does have its drawbacks. We did have electronic care planning and were one of the people that crashed with the NHS 111 crash that happened recently. So it's not always positive, but a good way forward. So I've gone through two. Debriefs after a death. This was something we'd started before. An Oscars project, which a lot of people will be aware of. But this was a chance for people to properly reflect, to stop that busyness of buzzer and person and somebody falling and this happening and that happening, somebody's off sick, and to actually sit and think, do you know what, we did a really good job with that person. You've only got one chance when somebody dies to get it right. You want to get that right. So to be able to have that reflection, but also if it didn't go quite right, not to blame anyone, but why didn't it, and what can we do for the future? And that one has really kind of taken off and grown arms and legs into an Oscars project, which is covering many more. But again, like everything adapted, went online, specifically so that a lot more people could be involved in it when there was no face-to-face contact. Student placements, which is one of my personal sort of passions. We've got a couple of our students with us today as well. This is where it begins. One of your questions to James about changing the mindset of acute nurses. Yes, brilliant, but it's actually everyone. We all work in multidisciplinary teams. So to change the mindset of the physios, the social workers, the occupational therapists, of paramedic students, speech and language therapy students, just for them to see how important it is what we do within care homes. So there's a poster about that as well down at the marquee if you want, and I'm around if you wanted to ask anything more about those. Medication, there's a lot of conversation with that, and this is a great way of getting links into people you wouldn't normally come across, the sort of, I don't know what a technical name is, but a high-hygiene pharmacist person. I'd never get to see. But I'm in a room chatting to somebody and getting some really good information about them and about what they do. Support within the pandemic. What do you do? What do you do about this? What do you do about these guidelines again? And actually, sometimes there's a really good merit in just being able to go, and yeah, shouldn't be underrated. And that's only a few of the bits we've done. So all of this was up and running. But what happens, I couldn't find another slide, what happens when the main person goes? What happens when they exit stage left? Jo very rightly is trying to retire, not very successfully, but she's trying. So it was time for her to move on. But CHIP had really gained momentum, so why would we want to stop? But what do you do with it? Sort of floating in midair. So ENRICH came to the rescue. Susie and Lucy were already part of the team. And it seemed to make sense. All the stuff we were talking about peer support, about collaboration, about innovation, that all feeds into research. Now, I don't know about speaking just purely to people within care homes there. I was petrified of research because it was like, well, it's just far too much like hard work. I don't understand it, and what on earth does it do anyway? Not that I was being negative, I just didn't know. So by joining, what we realised was actually we do research every day. The couple of little questions which I saw sneaked in earlier of, how do you feel that this has moved around? I thought that's a sneaky wee question, because that's research. That's you reflecting, that's you answering back. But what's great about things like today, who knew all this was going on? And the project in Glasgow and whatever, I was like, that's really exciting. I'll have to have a chat with you about that afterwards. But it's looking at what we can do. How can we change things? How can we alter things for the future? So what has got the future for us? As far as we're concerned, we want to continue doing this. At the moment, we now have, I think, 7 care homes. We've got another couple that are joining us. We have people that have left one care home who was part of it, who are then going to be coming back. They've moved care homes, so they're going to be doing that care home in. We have 2 care homes. One of them had been very active, the other hadn't. We have a new manager who's also here today, and they're going to be doing more as well. But this is about us informing the future. It's not about us just passively sitting there and saying, oh, great, more stuff. It's about us saying, actually, we want this to change. Let's help this to change. Let's do something about it. So, rather dramatically, part of the poster as well, plans for world domination? Well, maybe not quite so much, but maybe just plans for more chips. And I don't know about you, I've always got room for a few more chips. We have already started, there's one that started up in Glasgow. And myself and Susie Schenken will be doing the workshop this afternoon. looking at some of the questions that potentially we could ask about CHIP, different work that we could do, and how do we progress that. And also we have come up with a toolkit so that if anyone is interested and wants to perhaps have a collaboration that's a care home innovation partnership, and it just ticks all those boxes. So if they want to, we have that, and we're all available if you wanted to speak to us afterwards. So I think I'm probably a bit ahead of time, but that was what I wanted to say. So thank you very much.
Terrific, thanks very much, Cheryl. And while you're thinking of your question in the room, from Slido, where you can also post your questions even if you're here, somebody's asking a very real question. Is there a danger of too many new ideas coming out at the same time, especially post-COVID? Is it too overwhelming for care homes?
Oh, yeah, interesting question. I guess the answer is both yes and no, which is very vague, I know, but I think it could be. But the whole point of the partnership is to discuss things and I guess prioritize. Having hundreds of things out at once is just too much. But there are lots of things that can be going on, but from different people, different sections of research. So I know there's several different researches going on at the moment, but they're not necessarily overlapping. And again, a lot of it is about the partnership element. It's about that discussion. But if it wasn't managed right, yes, you're right, it could run away. But there is something about coming to days like today where you're inspired, where you've got that iron sharpens iron. You go home thinking, oh, actually, even if you take one tiny thing away from today and you all implement it, look how much implementation that is, not including the people online. Don't know if there's anything else you'd want to add to that, Susie.
No, I totally agree. And I think the other message from today is we're trying to get over care home research, think ENRICH. We would really like to try and be that hub so that if people have an idea for a research project, we know about all of them and we can say, actually, somebody's already doing that. Why don't you link up with that person? And instead of having another new idea and overburdening people with new things, can we try and make it, bring it all together and do that in the future? So that's why why ENRICH was started and the vision that we've got going forward is to really try and be that hub and resource for people to do research, but to try and avoid duplication. So very much aware that we don't want to overburden people, but we do want to answer the questions that are important to you. So it's why it's important that we hear from you what you want to do. One question here.
Hi, thanks. Sorry? Yes, so I'm Caris. Hi, I presented earlier on ARCH. So I'm interested, so I'm a great believer in tests of change and innovation just as part of practice. But I'm curious how you think it fits in with research and where's the line, when does a test of innovation and a practice evaluation become research and publishable, and when does it need approvals? And it just, it's not an easy question, but just because obviously you're within ENRICH, but you've kind of come forward saying it's not research, it's innovation, but how do they fit together?
I would say it fits together probably at the planning stage, at the collaboration stage. That's why, sort of mindfully chose that as the first thing. It's that collaboration, it's getting together of ideas and people. And for example, regarding the recruitment, we met together and one of the things was about student placements. We could discuss that, we could develop them, we could share ideas, we could have more students on board, get in touch with universities, and we did all that. And that wasn't really something that was kind of a research base. However, the beginning of the conversation was, how do we get more people involved in care homes? How do we get more staff? What do we do? It's at that point that the ENRICH team are like, actually, do you know what? That could be a piece of research. So by having that conversation, I guess it probably goes in both ways. You have the test of change done practically hands-on by the care homes, but then the things that we are unable to do the test of change with or that need more verification would go towards the research base. So it's more around the round table discussions would create those things. Does that make sense? Yeah?
Great, thanks very much, Cheryl. We better move on to the next talk, but thank you for that. Another round of applause. And our next speaker is Professor Liz Forbat, who's come from the University of Stirling today. I'm looking forward to your talk, Liz. Thank you.
Sorry, I'll get out of the way in just a second.
Microphone doesn't switch on, then I will. Ah, gutted. Okay, well, hello. I'm aware that most of you can't see anything more than my eyebrows and up, but never mind. Okay, so my role here is to kind of take a bit of a step back and to throw open some ideas and reflections about kind of when does it work well in care homes and like who's doing what to make it work well, or maybe less well as well. So a bit about me and why you should pay any attention to what I've got to say. I mean, maybe you shouldn't. I've been doing research in care home for about 20 years, thereabouts, and have used all kinds of different designs, different ways of conducting research. So you can throw questions at me about all sorts of things. I've chucked down some of our researchy words up there for those of you that speak that language. But yeah, so I've done all sorts of different things, so can draw on that when I'm thinking about like what's working in care home research and what doesn't. And from those designs, loads of different methods, and you've heard loads of those from different speakers this morning. And I've also written ridiculous numbers of books and journal articles on it for anyone that's interested. I haven't actually been in a library, though, for probably 5 years, so don't be too put off by that. I think that there's something about researchers often kind of framed as not being in the real world, and that we're kind of constantly surrounded by kind of stuffy libraries and so on. But like I say, I'm out and about, or I'm just stuck in one small corner of my house on Zoom meetings. So care homes, you all know just how complex they are. And I think that's one of the core things for researchers to understand about just how complicated the systems and structures are, and about what goes on day to day and strategically in the care home sector. So for researchers to understand all of that and to integrate that into how they set up research and how they deliver it and then how they communicate findings is critical. And one of the things we don't want to end up doing is to kind of play some sort of guessing game of where are you, what's going on, who are you, what do we need to be achieving here. So very much the stance of it is to kind of take those hands away from the eyes and to be clearly communicating with each other. So we don't want it to be a guessing game about what people might want, people being care home residents, care home staff, managers, government, all of those. We need to be able to see clearly and to communicate that. One of the things that really motivates me, and which I've heard all of the other research-based speakers today pin their talks on really, is about the need to make change. Like, I think, again, there's this kind of idea that academics are just interested in ideas, and actually all of us want to see improvements in practice. That is what gets us out of bed in the morning. I'll give you a wee snippet, just one little quote from a study that I did a few years ago. We used this intervention called needs rounds, and that's just one of the most beautiful quotes I think I've ever seen in relation to one of the studies, and it was about a palliative care intervention, and that idea that they hadn't had a bad death in the care home since they'd started using this intervention that we were testing, is enormously motivating. So I think that's kind of one of the core parts about when it works well, is when we can all see what difference it might make, and having an agreement about what an improvement in practice looks like. So you've heard loads of people this morning talking about co-production, and I'm not sure whether or not that's familiar language to everybody in the room. But to my mind, essentially that means that it's not down to the researchers to decide, I'm interested in this research question, or I'm interested in that. But it's about researchers and people working in care homes and people living in care homes and relatives and friends of people living in care homes all working together to decide actually what are our shared goals. Because if we're just working from the perspective of one of those people, then we're going to mess it up, basically. It's not going to hit right. So that shared goals is absolutely critical. When it also works well is when there is care home management support, and lots of examples of that from my own work where you kind of need that kind of buy-in, particularly if you're asking something from members of the staff and residents and relatives to get involved. I'm going to unpick that a little bit more in a couple of slides' time, and a bit of time to take part. And I know that is a massive, massive issue. So often what we need to do then is to think about and co-produce, co-design, work together about what actually might be manageable. So if I'm saying, oh, I'd like you to come to, there was a question about short interviews, and is 45 minutes or an hour short interview. So let's co-design, like actually what might be achievable. How do we manage this? How do we actually create a research method, the way in which we collect the data and information? How do we design that together so that it is actually feels manageable and something that you can say yes to? And strong relationships is absolutely critical. I don't think we can achieve anything in our lives without that. So again, as Susie's been saying, like use the relationships and networks that you've already got today, but expand those and grow those, because that's the absolute core of it. So I'm wondering, like, do you know what you can expect from researchers? Like the researchers in the room know, but do people working in care homes and people in other sectors know what you can expect from us? Or is that like a bit of a black box? Yeah, right, like who are these people? So number one, massive amounts of enthusiasm. I'm trying to sit on myself a little bit just now, because otherwise I'd be like, oh my God, it's so... But do you know, genuinely, people doing their PhDs, from PhD students through to professors, we're all just so thrilled to get the opportunity to work with you and to shift practice and to understand things better so that things can change. So you can absolutely rely on us for that. And I know enthusiasm in care homes comes with different workloads, and maybe we can help keep you buoyant in that respect. And we've got so many interests. I would challenge you to find something that I'm not really interested in, which may be one of my failings, actually. Anyway, and engagement, like we are going to be there for you. If you want to email us in the middle of the night, we're going to be probably reading our emails. If you want a phone call with us, if you want to send us a carrier pigeon, we are there for you. So yeah, you can well expect high levels of engagement from us. Quite often in studies I do, if it's helpful to the care homes, I'll give them certificates of participation. A couple of weeks ago, it must be RCN re-registration time for people with their CPD. So I was writing letters for that. Yes, this person's taken part, and yeah, they, and again, boundless enthusiasm for supporting the RNs to renew registration. So yeah, you can rely on researchers to support you in what you need to do. If you're going for, if you've got inspections coming in and so on, we can give you stuff that helps you build your portfolio around that. Absolutely. But you can also expect paperwork from us, sorry. And yeah, we can talk a bit about that later too. So yeah, so there is a bit that you would expect from us to maybe put out information sheets, put up posters, hopefully not tell you off putting up the wrong version poster. Thank you to whoever mentioned that earlier. That kind of stuff, so absolutely. So when does it go well and when does it not go well? So I want to show you my favourite image. I don't know if anybody knows this image. It's a fresco, one of those, I think it's a couple 100 years old, painting on the wall of a church in northern Spain, and became very famous about 10 years ago because somebody went in and tried to restore it. And unfortunately, what happens when you're working with boundless enthusiasm but not skill is the restoration, and it doesn't go well. So it's a cautionary tale, I think. I hope this is not offensive to anyone that carries a Christian belief. But I think it tells a really important story about partnerships and about really understanding about where people's skill sets are and about understanding the context in your work in which you're working. So if you take nothing else away with you for today, take that image with you. So how do we avoid creating the monstrosity on the right-hand side there? Or maybe it's not monstrosity, maybe that's okay for some people. So So I had a look around, being a good researcher, had a look around and thought, well, what are the other things that people have already determined about what works well and less well for research? What are the kind of characteristics and features that need to be in place? So, lucky for us, a researcher called Helen Lamb did a systematic review. Now, what that basically means is that she and her team spent probably about a year reading and scanning 2,500 articles, all of which were in some way or shape looking at what are the challenges of doing research in this. Now, that's American language, long-term care facilities, but it's the same set of issues, really. So having a look at what Lam had said in this paper, these are the things that she and her team had come up with. So there's all sorts of challenges around that. So we can unpick those a little bit, maybe. So facility owner administrates. There's lots of stuff there. So if it's part of a wider group, then maybe there are governance things and you need to you can't make a decision in your care home, it has to go up the scale, and that slows things down, and maybe somebody up the scale doesn't understand the local context, and maybe they're going to say no even though you want to say yes, all of that kind of stuff. Sometimes facility owners are a bit scared about or don't understand research. You all do because you're all here, but that can be another challenge, thinking about whether or not they understand what the potentials are for engaging in research. They were identifying stuff to do with residents. So sometimes residents don't want to take part in research. Let's say it's a randomized control trial. So that's where you say yes to the study, but you don't know if you're going to get the blue pill or the green pill. And lots of people, including people not living in residential care, don't want to do that because they really want the green pill and not something that actually might just be a kind of sugar pill equivalent. So lots of residents might say no to research because actually they don't want the uncertainty that brings. And of course, other residents might have compromised cognition, and there might be issues about whether or not you feel like they could easily consent. Say, if it's a study where somebody was talking about observational stuff, you had a beautiful phrase about kind of deep lurking around type idea. So could you actually get somebody to consent to that? So there's lots of questions there about resident-related factors about whether or not the research could happen. Then you've got staff things. So as well as the facility managers, maybe staff aren't really sure about what the research might involve. Maybe they don't have time, back to that idea about how long interviews and so on might take, those kind of considerations. For families, actually one of the best recruiting studies I've ever been attached to was recruiting families impacted by the pandemic, where they weren't able to go in and visit their relatives. I'm sure many of you are still carrying the stress and trauma from having to have those conversations with families and residents. And her study recruited phenomenally because these families were desperate to be heard, absolutely desperate. And we were desperate to hear their voices and to then feed that back to government and to make the change, right? So not just information for the sake of research, but to push change and to seek to enter into the dialogue around Annie's Law, that kind of stuff about visiting. So families might be hesitant to take part because they hold some of these same ideas about not really understanding it. Maybe some of them take on more kind of paternalistic ideas about wanting to protect their resident or their family member and so on. And then there are investigator issues, which maybe also come in. One of the questions I'd encourage you to ask investigators or researchers, that's the same thing, right, is to say, well, have you ever done this kind of research before in a care home? Like, ask the question. Any decent researcher will be able to answer that. And if they don't say yes or no but, then you're going to know what you're kind of getting into there. The ethical and legal stuff, that all circles back around to things like consent, those kind of issues. And methodological. So I mentioned, if you're choosing the wrong kind of method, if you're choosing a kind of blue pill type thing and you don't think that's going to work in your setting, then that's also going to be a barrier to research. So again, that goes back to that co-design, co-production, working together so you don't end up with that weird looking Jesus thing, so that you're saying, well, actually, no, a red, blue, or whatever, you know what I mean. That thing, that's not going to work here. But what you can do is to come and observe what we're doing in the care home. And then budgetary. So research costs money, and that's a given. Researchers often spend a lot of their time raising money, looking for research funding to enable that, and some of that might be able to be passed on to the care homes. So one of my big studies at the minute, we're paying care homes to take part in it and to sort of send us bits of information about their residents. So for all of that stuff, I'm saying we can hash out some of those words, we can hash out the challenges, and then just look at actually how we get to be that smug cat, saying actually, yeah, let's do the co-design to sort out the methods. Let's work together to communicate why it might be useful to take part. Let the researchers take care of the ethics, like that's their job. But say to them, oh, I'm a bit worried about this. That's fine. Any researcher worth their salt is going to want to hear those concerns. So work with us. So I guess the kind of final scenario I want to throw out is like, what would you do? And maybe you don't have a research idea, but maybe you've got a clinical problem or a management problem or a staffing issue, and talk to researchers about that, because that's our bread and butter, is turning from problems into research and therefore solutions. So there's your conclusion. Let's build networks, punt the ethics stuff to the researchers, but talk to us about what the concerns are. Let's work together around the costs and the times and all of that sort of stuff, and make sure that the researchers are really being aware of the context in which you're working. But mindful that lots of us have spent a lot of time in care homes, and many researchers have worked in care homes, and we're not kind of sitting in dusty libraries just poring over books. So thank you for listening and for being a lovely audience.
Thank you very much, and I hope you're all getting a better picture of all the things that you can do, we can do to help, and how we can work together in that. What questions do you have for Liz? Well, I find the one on here. I'm not just surfing the net. The question that came in on Slido, Liz, was wondering how shared goals process works when goals might clash. In other words, how do goals get prioritised?
Well, I suppose through discussion, really. It sounds like that's potential for clash between researcher goals and care home goals, maybe? I don't know. Oh, do you want to speak to that? Microphone incoming.
Yeah, I really like the idea of you were working with all the people within the care home, so residents, family members, staff, researchers. And it strikes me that it's great. I really like the idea of having the shared goals. What are we all working towards? But it strikes me too, there are lots of situations when goals might reasonably clash, and they're both good goals. Mm-hmm. So what's the process of deciding how a goal gets taken forward? I'm thinking, I guess, of power relationships, because there's a lot. How would you negotiate that between a family member, for example, and a member of staff who's a care worker versus a member of staff who's management, so on and so forth?
Yeah, wow, what a great question. I mean, I think it does come down to the relationships and having the conversations and being explicit about the power relationships. And I'm really glad that you used the P word, because it's so critical to the work that we do. And I guess from my point of view, often the goals aren't necessarily utterly clashing. It's not tectonic plates kind of smashing into each other and making people fall over. It's about thinking about how do you design a piece of research that can address multiple people's perspectives and viewpoints and priorities. And maybe it is about prioritization, and first we do this and then we do that.
I had a question, Bob Fisher from Edinburgh University. I have a question about managing expectations. I mean, as a researcher, I know how things never work as well as you would really like them to, and most things never turn into anything real afterwards. They turn into a paper, but for various reasons, there's just no justification for going forward. And I could see how the care home and all the people who volunteered to make space for us to do our research might be a bit disappointed by all of that.
Yeah, and I would be pretty disappointed by that too. I mean, I think that there is some power, not only in the researchers getting funding for it, because that means that maybe there's funding that can flow through to the care home, but usually funders now insist that there are clear changes or outcomes or dissemination and communication that come along with the research. And I think, if you're involved at those early conversations about what is the research, what are we doing here, then you can get those questions in early. Like, okay, so that sounds like a good idea for a topic. How's this going to change things? And then you build that in. Sometimes that means that you need to think really differently about what your methods are. So one of the methods that I use quite a lot now is called implementation science. And because it's got science in it, it makes it sound very fancy. But essentially what that means is that you take stuff that's been written about and you work in practice about how do you implement that evidence, and to understand about the kind of context in which people are working, what mechanisms enable or stop things from changing, and what outcomes people agreed that they want to look at. So it's maybe a pivot to those kind of methods rather than other methods where it looks less clear actually what the outcomes are. One of the benefits of the blue pill, red pill thing is that at the end of the day, you probably know which pills best to use with people, right? So again, thinking about what kind of designs might be quite helpful, where there is a clear outcome for it. But I think anyone in here that's working in a care home and is wondering about, is this research that ENRICH are talking about, that these researchers are talking about, is it going to make a difference? Come and ask us, have that conversation. And if we can't answer it, then say no. Say no. I would. But I don't think you will have a no. I think there will be a response to that.
Hi there. From a small, Neil Armstrong from Thornfield House in Selkirk. From a small independent provider perspective, and relatively new to the sector, although we've been running a while, the biggest challenge or barrier that we have in terms of research is the resource constraint, and we want to fully engage in these research activities and best practice, collaboration and sharing, but it's having the resource or the budget to be able to to actually engage, take that time out, backfill the staff when they're on the floor, and that's something that needs to be passed back into the government level, public sector level, that we could be a real source of knowledge and research, but at the same time, if the government want that output, they need to fund it and resource it to enable us to engage.
Hallelujah. Yeah, absolutely. And within the NHS now, researchers have to fill out this ridiculous form called a SOCAT, which documents exactly what NHS staff are going to do that's research related, which is sort of extra cost associated with new treatments, that kind of stuff. And we have to do that for NHS, but we don't have to do that for independent or for social care. And I think no matter what massive pain in the butt that form is, actually we do need to clearly represent the amount of time and energies that come in from social care and the independent sector. Yeah. If you see anyone from government, you can make that point, and I will do too.
Swiveling to people in the audience. Great. Well, thank you so much, Liz. That was really helpful. Thank you again. So we've heard a lot this morning from lots of different perspectives. I hope your minds are all buzzing with your great ideas and thinking of what to do for the future. Our final talk of the morning is going to be Rosie Ashworth, who's going to give us the patient and public, and Anna as well, double act, talking about how we engage other people in research, talking about the rich voices, and we're very excited to see the technology appears to have downloaded the slides, which has been a stress all morning, so grand news.
It's not because there's loads of slides, it's because there's a video. I should preempt that because it's going to be the pre-lunch talk. So, it's working. Fab. So just to firstly introduce ourselves, I'm Rosie Ashworth. I'm the co-lead for Rich Voices, which stands for Research in Care Home Voices. And I'm also the lead for Partners in Research for the Neuroprogressive and Dementia Network. So that's where my kind of PPI hat transfers over. I'll hand over to you to introduce yourself a bit.
Hi, I'm Anna Crawford, and I am the PBIE officer at the University of Edinburgh. and I work within the Advanced Care Research Center. And I've recently joined Rosie working on Rich Voices, or ENRICH as the wider program. And yeah, that's...
So the group's primary focus is on working with people living and working in care home environments, as well as family members, loved ones of those living in care homes. One of the kind of preempting issues that are going to come up is that this is a new group. We're trying something new here. It's not been done in many places before. And obviously, when you're starting a new group, you can want to include everyone. We don't want there to be a kind of exclusion criteria. But of course, we have to start somewhere. So there will be an element of we'll have slightly kind of heavier voices on one side for a bit than other sides, and we're aware of that. And that's just something that as the group kind of evolves, we'll be able to create some space for. But this is the big test, whether this works. So I always think if you're going to talk about patient and public involvement, it feels weird that it's us talking about it because we're just one part of that. So luckily for us, lots of other people have agreed to share their thoughts about why they're interested in Rich Voices and the sorts of things that they hope to see over the next kind of year or so. So I'm hoping, do I just press play? Hopefully. And let us know if you can't hear it, but it should.
My name's Leslie Cousland. I'm one of the clinical studies officers with ENRICH Scotland, and I cover the Tayside area. I think I'm really interested in Rich Voices because ENRICH itself, one of its main priorities is to support and engage with care homes around a research agenda. And I think involving people who have lived experience or people who have just got an interest is one way to move that agenda forward.
Hi, I'm Martin. I should actually be in a care home now, not as a member of staff, but as a resident. My physical symptoms are too bad, but the neurologist has said that the research I do is actually keeping me out of the care home. So when I actually do go into the care home, I'd want to carry it on.
Hi, I'm Anna Bryan. I'm a researcher, PhD student at the University of Edinburgh in the Advanced Care Research Centre. And I thought I'd join this group because my research looks at the use of music in care homes. But I'm interested in how we can involve the whole community of people and stakeholders involved in care homes and getting perspectives from staff. So I think also just getting to sort of meet the group, be a part of this and learn from it, and also be able to chat about my work would be great.
Hi, morning everyone. My name's Jenny Robertson and I'm also from the Advanced Care Research Centre at the University of Edinburgh. So my role is for patient and public involvement and engagement. So obviously I'm very passionate about involving members of the public in research, and we know that care homes are a kind of under-researched area. So I was really pleased to see this group get set up and keen to kind of spread the word and get more people involved in research. Thanks.
My name's Emma and I'm a practice development nurse with the professional practice development team at NHS Tayside, based out of King's Cross Hospital this morning. But I have a remit as part of my role for supporting person-centred practice in care homes in Perth and Kinross. I suppose I was interested in this because I'm interested generally in research. I'm just about to go and do another master's module with Queen Margaret University, and I'm interested in research and where it comes from and how it informs practice going forward, but also just like many others that have already alluded to, just hearing those voices of those delivering the care and receiving the care that we're providing is really key, and sometimes they're the difficult voices to hear. You tend to hear from those who have a bigger platform. So I'm just really interested to see what work we can do and how I could contribute from it and learn.
Hi everyone, my name's Maria Drummond and I'm the Senior Clinical Studies Officer at ENRICH Scotland. I'm interested in Rich Voices because when I was a PhD student at the University of Glasgow, I worked with community members who helped support me through my research, and I know the value that it adds. So I'm sure that it'll add so much to care home research in Scotland.
So my name's Anne Morrison. I work with the Dementia Liaison team in Angus. So I work for the NHS, but we support care home nurses to look after people with dementia. And my interest in this group is because I think there's a vast amount of work out there that care home nurses are doing that's probably going under the radar and not recognised. So I would be really keen to get the work that they do in care homes with people with dementia recognised for what it is.
My name's Claire Cameron. I've worked in dementia care for about 10.5 years, all in care homes. I've been a nurse and I've also managed care homes as well throughout. So I've worked, in quite a lot of settings and things as well. I've seen lots of changes throughout the years as well in care and what we are doing as well. So I think it's really important for groups like this to spread the word about all the really good practice that we're seeing, the challenges that we're facing as well, not just, and for the residents to get their voice out as well, because it's really important, and we are advocating a lot on behalf of those residents, whether they really need to have their own voice as well.
I do think that's going to be one of our biggest challenges, and probably if it can work, one of our biggest successes is we can get more voices from people who are living in care homes and, finding different ways to promote that engagement.
My name's Jeanette Barclay. I work for East Ayrshire Advocacy Services. The reason that I was really interested in this, I go around 18 care homes within East Ayrshire and I attend their residents' meetings. And my role primarily is to make sure that their voice is heard. So that was why I was really so interested when I read, the remit of the group.
I'm here as part of ENRICH team, and I support ENRICH with research governance, which is really boring. By the same time, if you are to unpick it, it allows care home, as we all know, is such a unique environment, and proper research governance allows us for many projects to happen if it's put in place, because integration, as it happened in Scotland, care home probably is the best example of health and care staff meeting together, working on common grounds, trying to find the best way to support residents and their families. It's that important that research in care homes is demystified, and we can only start by demystifying the community itself, because we have, unfortunately, Scottish Government they have done a lot of good work, but they have done a lot of bad work, and we have to accept and reflect on that. And social worker was saying it's the best place for him to be at home. Well, no, it's not, and it's demystifying and doing all this work. The best place is the place where you want to be, and the best place is where it's best for you to be. So I think, I'm here to support that demystifying of what care home is, trying to engage with the workforce in a dignified manner, knowing how, busy and how overworked they are, and what is there for that workforce. What is there? Why would workforce would want to take part and give their precious time away to participate or support a research project?
What jumps into my head would be, as a starting point, demystifying what care homes and residential homes and nursing homes are all about. You have to spend a long time just explaining what care homes are about and what, and how they operate. So I think that's within my own practice development team. So I think there's some work to be done there. So it'd be nice to see something that focused really strongly on just educating.
I think you're absolutely right. It's changing what everybody's concept of a care home is. I'm actually quite ashamed to tell you this. When I started this job 4 years ago, I didn't really have any idea of what a care home was all about. And when I went in and these people were having parties and they were going out on bus trips and out for coffees and everything. And when I speak to people about care homes, they think it's the end of the road. But it's not. It's a completely different new chapter in their life. And it's the most amazing thing, supporting people moving from home or hospital, get into a care home, and you see a massive improvement in them. This wee lady asked me 4 weeks after getting into a care home if I could take her in lipstick, and that was just amazing, where she had no interest in her appearance before. And you're right, it's seeing the staff and the interaction. And I went to a residents' meeting yesterday, and this gentleman was saying, all these people here are my family. and it really touched me. It's like a wee community within itself, and it's trying to break down the barriers and getting people to understand what a care home is actually about and the advantage it has to individual people.
If I go into a care home and I get sat in front of a telly, I'll be telling you behaviour straight away, because that's hell to me. Having worked on the shop floor of a care home as a care assistant, those of you who go around care homes, what you should be looking for is the person that will go the extra mile for the residents. I'll be in a care home within 5 years, but as long as there's Wi-Fi in that care home, I would expect to carry on co-researching like I am now, basically, to be honest.
We need to engage with care home staff and families more at grassroots level. There's so much we could do, and we do need to kind of rein ourselves in a wee bit, I think, and just take it a step at a time.
For me, it's just basic communication, whether it be technology or whether it just be speaking. I think that's what the problem is. It's just trying to get the word out to everybody.
I think time is always an issue for for anyone everywhere. To explore that with people in care homes is probably the way ahead with that. It's not about me saying, well, this is how we could fix that, because that's not. But also getting the information and the misconceptions. A lot of people perhaps, who work in care homes, care assistants, chefs, gardeners, people who do lots of different roles may not have, I'm not going to say won't have, but may not have an understanding of what we mean by research in the first instance and how they can get involved. So
I would say most of the shop floor workers, as I call them, do not, certainly 6 years ago, they certainly didn't know that you could do research. I didn't know you could do research.
The word research can sound really intimidating to some. It's not clear what that really it can maybe have connotations of scrutiny involved in and amongst that. So I think there's so many people looking to do work with and to and among care home organisations that I think we've got to have a USB. There's got to be something that really sells us as what the care home sector can expect to get back. So I think that's the key, is what is it going to be in, and not in for society as general, because they're just working this firefighting mindset at the minute, that what is in that for the actual care home that wishes to get involved, and that's every stakeholder within that. What can they expect to see out of this? And I think that communication, I agree completely, really important. And I think we can't overestimate the importance of listening. So communication, thinking about that as not as how we're communicating and how we're selling this and talking about this and explaining it, but really how we're listening actively and really deeply to those and their concerns and addressing those questions honestly as well.
Scottish Government guidelines are very heavily against sedating, what I call a chemical course. And if I didn't do research or have some meaningful activity, and I mean age-appropriate meaningful activity, I would have to be sedated. So that's the answer. You're following the Scottish Government guidelines, basically.
When I worked in care homes, I didn't, like you, didn't realise that research was something that might happen in a care home or with residents or staff, but could never have found the time to do anything like that in my spare time as like a young student working really hard, and my shifts were my weekends, my weekdays were being a student nurse. And for me, what I see care home research is like trying to build that into practice and prioritise it. And when someone has a cancer diagnosis now, it's quite like normalised that you'll hear people be involved in new treatments or part of trials, and it's quite a positive frame that's put in, and it's something to talk about, and it's something quite exciting. So that's what I'd like to see, like residents and staff having similar opportunities to other diagnoses and other groups in society, and that it is part of what's likely or expected when you get to that stage or you have a certain diagnosis.
One thing that might be a barrier to getting like the diverse range of care homes that are out there. So maybe like some care homes that are more well-resourced might have more capacity to participate in research. So making sure that we're finding ways to engage with all like care homes, and also in different geographic areas as well that might have less accessibility. So thinking about the types of like, I guess, convenient sampling that sometimes happens in research and how we can sort of push past that. But it is like a barrier that I think will probably be faced.
Just one other little thing that just jumped into my head, really. I think also bearing in mind the idea that these are businesses and that they have reputations to uphold and what have you on a very local level. So I think it's kind of not spinning it, but if there's this, the cutting edge, they're leading, they're helping with research, would be really, you can see the appetite for that among a business that's looking to, sort of showcase what they do. If there's any sort of suggestion that something's not working right, therefore research team are coming in to see how that can. So I think it's just about the language, isn't it? And how and getting into the mindsets of some of the small businesses, and what's in it for them might be that their care home will stand up shoulders above the rest because they look as though and they're rightly so, and they're actively engaging in this and helping the sort of what's going to happen in the future. So I think maybe that's just again around language.
Once I'm in a care home, you'll be bombarded with practical suggestions.
Whether we call it research and how we kind of get people to understand what that actually entails, and the huge range of research. Maria was talking about the kind of clinical trials and the fact that as a network we have lots of clinical trials, but we also have, there's interviews, there's surveys, there's observations, there's all these other ways of gathering information that aren't maybe as well publicized, or the value of them is maybe not as well understood. There is so much kind of engagement and passion just in this group alone to try and change what research looks like from a care home perspective. So I'm just going to show you, it was better in their voices. Thank you for those of you in the room who are in the video and had to put up with the cringiness of seeing yourself in video. But just to note, a couple of activities that we are kind of looking into and working on based on some of these discussions include looking to do some kind of podcast where we can do kind of short stories of people living and working in care homes and try and tackle some of those things we've discussed about how people don't really know what it looks like to be in a care home. It's seen as this kind of very us and them world. So maybe we can try and, build those stories up and share them with people. We also know that as part of increasing research understanding, we need to make sure that research is accessible. So we'd like to look into some kind of accessible kind of platform where researchers can share their work in a very lay accessible way, have the option of people asking them questions, so that you're not just being asked to do research, but you feel confident to talk to people about research. I'm going to quickly go to some of the benefits. Hopefully the video covered a lot of these, and I know there was quite a lot of kind of links to what we've talked about this morning. But having a bit of space to shape the direction that research goes in, to share your story, and hopefully we can provide a bit of a platform for that and some space for that, as well as draw attention to some of the things that we might not know are issues. And it's important to have that time to kind of go, well, how can we not only recognize that issue, but what can we do to hopefully improve things? Final things to think about. We are aware with all of this, it's another thing that we're asking people to get involved in. And you've all got very limited time and heavy workload pressures. One of the things we're really keen to make sure is that the activities that we offer and we do as part of Rich Voices or PPI is very applicable to practice, so you can see why you're doing it, you can see why that time is being spent. But we also face a challenge in who has the power to kind of make some of these decisions, even about just getting involved, and how we manage some of those power dynamics that we know exist. We are in the early stages. everyone is welcome to join if they're interested, and to share it with others. And our new PPI inbox, which is very exciting for me that we have this now, is available. And you can obviously talk to myself and Anna if you've got any questions. But hopefully it's a bit of a whistle-stop tour to what we're doing, and hopefully it's of interest. So I will stop sharing now, or I'll leave that up there, and Neil can do it.
Yeah, just stay a minute. I'm sure there are some comments and questions in the room from people who are interested, not least from Jane, who needs to co-collaborate with you, your podcast / TV series / something or other.
I've already mentally signed you up for that.
Hi, thank you. Hi, my name's Sarah Swift. I'm a researcher, and I'm just interested in how you discuss sort of managing the expectations of people who might want to get involved in research. There was something in the video just then, someone talking about how research could potentially be used to improve a care home's reputation. Obviously that can be the case, but it shouldn't be the objective from the researcher's perspective. And I've certainly had quite a few colleagues who found out the hard way that if they have findings that aren't so positive, they have a lot of pushback from the care home or the care home owner. It usually comes from higher up, not to broadly stereotype. So I just wondered how you manage that expectation.
I don't mind.
Right. I'm assuming you can also hear. I think at the moment there's not a kind of ideal framework for how you manage that expectation. I think what we can hope to do is have some kind of transparent conversations about kind of, if you're doing research, who's accountable for the results, where some of those power dynamics come in. But I think a big thing that we found with the kind of other PPI group we're part of is the more people are just open and honest about the situation, at least then, even if it's seen as a smaller scale than maybe you'd hoped, at least you know that and you can then make an informed decision. But some of these issues, I think, come from people kind of coming in and over-promising that they're going to change the world, and we would all love to do that, I think we can agree. But it's about going, like, we're going to have to do this in kind of baby steps and celebrate the success as we go, but it is going to be a bit of trial and error because we're working with a lot of people with a lot of different priorities. So I think all I can really go with is be as transparent and open about things as possible. But it is going to be a really difficult thing, particularly when there are going to be things that people don't want shared, and how we balance some of that and make sure people feel it's a safe space to have some of these discussions. So we may need some separate groups where it's maybe a manager group and a staff group and have some of those conversations as the group grows.
Thanks very much. And a question from Slido, can you just explain PPI, a role in research in general, and why is PPI needed or important?
Want to have a go at that one?
I'd be happy to. So PPI stands for Patient and Public Involvement. My personal job title has the engagement at the end, and it's all about trying to enable a platform for those who aren't, I guess, normally participants or subjects in research to be able to actively contribute within this research process, particularly when lived experience is so specialized. And sometimes as researchers, personally I can feel that sometimes I don't understand or can't truly understand what people may be going through, and being able to enable that platform to be able to share that lived experience and enable a platform that has such open communication and honesty, but also transparency of the difficulties of the industry as well. So I would say that would be PPI.
One final question in the room, if there is one? No, if not, because you want to go and visit the penguins on your way past to lunch. Thank you very much to Rosie and Anna. A final thank you to them. And just a wee reminder then for a few housekeeping things to tee up the afternoon. Please stay. There's some really interesting things this afternoon which we'll hope will build on what we've done already this morning. So lunch is going to be down back where your registration was, down in the marquee, past the penguins. Favourite thing of the day, and that will be straight up after this. And after that, rather than you coming back here all together, you will then split up into your workshop groups because there's slightly fewer people here than we had registered, you will probably be able to go to the workshop that you want, but as a reminder for those that you've signed up for, the green workshop is Iris workshop, and that's Maria talking about really a very interactive workshop to talk about your reflections on the workplace and how you can build on that to do research, using the toolkit that she's developed and some guidance, which is really, really helpful. The second one, is the red coloured workshop, is the CHIP workshop, which is, you've just heard briefly from Cheryl and me. We're going to do an interactive workshop about how you might want to think about putting together your own care home innovation partnership, or any ideas you have for research in that framework. And the black workshop is the Arch workshop, where Caris, who you've heard from, will talk a bit more about new ways of working in care home and embedding them into everyday practice and building on the presentation she already gave you. So really a plethora of riches, so you'll get great learning from whichever one you go to, but please do go to that after lunch. We'll give you a reminder just about 2 o'clock. And again, do dig into the Slido for other questions. We'll pass those on to researchers and feed those back to you. Talks will be available afterwards, as will the presentations. And we really hope you continue to engage in the active research that's going on inside the marquee, so you can take part in research and see how that is really straightforward and can build some useful information, even just in a short time scale like today. So any other questions, do come and approach any of us at the front. Otherwise, enjoy your lunch. All right, thanks very much.
Could you give us a quick reminder of where all these workshops are?
No. Yes, I can. Yes, I can. The CHIP workshop is in here. The Iris workshop is It's great to see so much conversation in the room and so many new connections being made. Thank you all very much. I'm Susan Schenken, as we discussed before. I'm co-chair of ENRICH Scotland and also of CHIP, the Care Home Innovation Partnership with Cheryl. I'm a clinical academic, I'm a doctor, works with care of older people in a hospital, and also a researcher half the time. That's my background. I've done some research in care homes, and I'm a family member with dementia, and have lots of people in my life have been in and out of care homes as well. So touched by it personally as well as professionally, as most of you are, I know. So what we're going to do this afternoon is have a bit of a workshop about the CHIP. You've heard a bit about from Cheryl already this morning. You have the privilege to know that our session is the one that's being recorded and going out to all the people who are joining us online, and will be available for people afterwards. So if you'd like to turn and wave at the camera and just be aware that that's part of the discussion. Obviously it's going to be more involved for the people in the room who are able to take part, but hopefully there'll be some useful learning for people elsewhere. So really, as we discussed before, what we're going to talk about today is the key parts about what CHIP, how we developed our CHIP, you've heard about, and then really what are the key components and how you could work together to do something in this way in the future if you are interested in doing that. So I'll pass over to Cheryl.
Lovely, thank you. What I didn't do earlier was tell you who I was. You got the point that I'm Cheryl. I'm a nurse. I've worked in care homes for 29 years. Yeah, that's quite depressing. Not for the care home bit, for the fact that I'm that old. And I do remember the YTS scheme as well. It's very sad. However, my passion is really to make sure that we can help people within care to live as well as they possibly can, but more so to also support the people that work there, and also the relatives and visitors that come in. So CHIP has a huge, huge part of that to play. And it's something that we really feel very passionately about. So just as a reminder, it's a Care Home Innovation Partnership. I decided that it would be a great idea to try and do this. So thank you. I will just move on the slide. So some of you will get the reference to Morecambe and Wise, some of you won't. That's fine. But we can have all the right ingredients, but not necessarily in the right order. So what I decided in my wisdom that would be a great illustration of this, can I have a volunteer? It's all right, you don't have to, but would you like to have a bit of cake? Well, yeah. So the key issue with this is that it looks like, are you eating that or have you? It really is quite disgusting, straight after lunch. However, cake ingredients, absolutely, but they're not in the right setting, they're not mixed in the right way, they haven't had the heat, they haven't had anything else to them. So although the key components are right, the setting's wrong. And you will have worked with the person whose key components are great, but the setting's wrong, they're just not right for that setting. So at CHIP, what we really wanted to think about is, how do we get the setting to work? We've got brilliant people, great professionals, people that really care, but how do you get that to work? So I would say here's some I made earlier. I really didn't. But if I did ask for a volunteer now, I'm pretty sure, despite the fact you've just filled up on a really nice lunch, you might well be more inclined because they've had the right setting. I didn't make them. But the other setting is the fact that they've obviously had the heat, the treatment that they needed. I'm not saying for 1 minute that we need the heat. We have it, we don't need it. But it's about trying to get that bit right. So that was kind of what we thought would be a good way of introducing this, because it is really important that we know what we're doing and why we're doing it. We're also very conscious that CHIP is, I'm not an acronym person because I suppose nurses do, but academics do it so much more. However, CHIPs, chipped. Different chips, they're not the right chips. We also have a few more, just because I found lots of pictures of them, so I decided to use them. Again, not the right chip. So I'll hand over to Susie, who'll tell you just a very quick recap, because you've had lunch since you heard me. And then we'll go on from there.
I can move back over to this mic. So as you've heard, so the Care Home Innovation Partnership was a funky acronym, because we love an acronym, and now you've seen all those pictures, you'll always remember what the CHIP is, even if you don't remember ENRICH necessarily, or you might remember one and not the other, so hopefully you can get them together. But we're really all about tests of change and things that could lead on to research, doing that in collaboration between researchers, people who worked in care homes, care home managers, looking for things that were innovative in that setting, and that was a wide range of different projects that really involved peer support and was looking to do these formal tests of change using a qualitative improvement methodology, but then using that to inform research projects that could then use a research methodology to get transferable research evidence that you could use in different settings. And we have some examples of that. You've seen it, the posters, and we've talked about this morning. Oh, no, wrong button. So, you don't want to hear us talk, you want to do some work. So together, we'd like you to get into your small groups and think about this question, this research question. What would you want for your care home if money and time were no object? So that's a good thought experiment. Can you put some ideas down in the post-it notes and we'll put them over and we'll start to think about them. Cheryl's going to say a bit more about that.
No, I was just going to say that the post-it notes are for the first and the second question, so don't use them all. The other thing is I changed it very slightly just on the feedback flip chart. What would you want for your or a care home? Because I'm recognising that some of you obviously aren't affiliated to one particular care home. So it's what would you want for yours or a care home? We were going to give a time limit, but I think we're all right for time. So lots and lots of discussion as there was earlier, but the key points, we know we can't invent more time, we know we can't magic money out. Forget about those as being barriers. What, ideal world, what do you want? Okay? So we'll give you a good amount of time to have a chat. That would be brilliant.
Environment. There's lots of environment. That's perfect. It can go there. Residence environment. Yeah. Yeah. Okay, I'm sorry to pause this conversation, but we can pause the conversation here, but you're guessing what's coming next, right? I want you to anticipate what's going to be the next question for your brainstorming. So just think about that while we think. There's been some loads of really, really interesting things, and you know what we do. If we were being proper researchers, we'd sit down, we'd write these down, we'd really think about the themes that are coming out and do that properly as a qualitative piece of research, which we will do afterwards, and we'll send you that. But I'm really just trying to draw it. I was trying to make some links between them, but you've done too many things for me to do it in this time frame. But really, there's a lot coming through about staff, obviously about staff well-being, staff working together as a team, having more staff, what you can do as part of that, but students also being part of that conversation. Quite a lot about the environment both for staff and for residents, how it caters for everybody's needs and allows flexibility, like getting outside, like daily hair and makeup. I don't know if that was for staff or for residents, but they both sound good. Sensory integration room and things like that. There's a lot about the workforce being mobile, being flexible, being a multidisciplinary team, exchanging knowledge, how you can do that, and again, doing the things I want to do when the time is right. Again, is that for staff or for residents? But both of those are really important, and having acknowledgement and reflection time and time to support people and make that positive. So there's a lot of really interesting things, and then some very aspirational stuff about gyms and cinemas and bars as well as part of the environment, which is interesting. Yeah, so we're getting some great ideas for our new care homes of the future, but a lot of this is within our gift to think about and to try and improve things to try and make this better for everybody. So I'm really, really interested in your thoughts here, and I'll try and distill that better, but that's a flavour of what we've got.
Absolutely. Just brilliant and so interesting. And the thing is, if you remove time and money, which obviously are massive factors, if you remove those, your brain kind of goes into overdrive. Oh, we could do this, we could do that, we could do this. Sometimes we know that that's not in some ways a possibility to do this, but even if we just move up a little bit, we've improved the service. The Care Home Innovation Partnership is basically what you're doing. It's having a collaboration. Then it's taking a couple of these things and thinking, how can we move this on? Is it a research thing? Is it a research question? Or actually, is it a practical thing? Is it a case of sharing really good practice with the couple of other care homes that you don't usually have time to speak to? And that's what the collaboration's about. It's the right setting, it's the right ingredients. So you've got the ingredients, you've got the setting, but it's what do we do with it now? And some of that is to pass on to research or whatever, and as Susie said, that's exactly what will happen afterwards. We'll have a look at some of these thoughts and see, well, you know, can we look at some research projects from here? But in the meanwhile, what is it that, sorry, you can now can't actually see that because I've got the boards in the way, but what would you need to do this? In order to achieve your holidays in the sun, like that one, your daily hair and massage, your staff well-being, a good staff recruitment team that you know doesn't move on, all those things, what do you need to be able to do that? So if you can go back to your groups and have a further conversation thinking about what you need to do. We know money and time will be right up there. So we'll take those as a given. We know that. But what else do you need to get those things done? Yeah? Okay, thank you. There's no more questions after this, so you can use all your Post-its.
Fantastic. Great. So I'll just quickly run you through these because I can't distill the themes because there's too many great ideas here. But you'll not be surprised that we'll start to see things coming through as we talk through them. I can't stand in front of the lion. So I think a really interesting thing that comes through all of this is about leadership and management, a little bit about who runs this. But so one group we talked about having the correct tools, the right people, good leadership, and support for that leadership, as well as transparency, which I think are really good points, and how to involve residents, family stakeholders. How do you keep everybody involved? How do you start engagement? How do you have the right policy? What did I say? Staff, rewarding staff, but it's not always money. How do you thank staff, but you don't have to pay them? And that's a really, you know this better than anybody. A thank you goes an extremely long way, but money goes somewhat of the way as well. And you need to really have that senior management, corporate support, good training, all different aspects, and know who can train in your team at different things. They may be in unexpected spaces. Looking at developing your specialist staff, how to have quality improvement, how to motivate staff, coming back to the rewarding as well. How do we increase the pool of nurses and I guess care workers and wider staff as well? How do we have a more structured framework? We could argue about how much structure you need and how little structure you need and when structure is good and when structure is less good. And making it a career pathway, and leadership comes through again. And having this shared vision of what is, why, and what could be. And I think thinking about vision and thinking about the vision in your minds, and if you've taken anything from today, just taking that little spark and thinking about what is the vision that drives you. It's a little bit of learning from today, I hope, having this time out of your normal work. And we need to appreciate the reality of current funding, but the opportunities there are as well. And I think creativity is a really interesting one. You know, can we be creative with the things we have, creative solutions and a can-do approach rather than a negative approach, which can be really easy to get into when things are tough. There's some interesting things about staff training, specialised staff training, to encourage risk-taking in a supportive way, thinking about linking into the community, freeing our minds, having good communication between everybody, residents, staff, families, and the extensive services, and space and time to reflect. And how do you make that in a busy job really hard? And how do we increase public understanding of care home visiting, listing? Living, understanding, public understanding of care home living. Perfect. And then thinking about care homes not being standalone things, but being part of the community. And those of you that work in care homes, some of your care homes will be very much part of the community. And that's a really important thought, I think. And something about planning, using a positive culture, positive risk-taking, with that word risk coming up again. What works for the setting? Can we co-design with residents, families and staff? How can we be inclusive? How can we value everybody? I think these are really important points. And so advocating the values of the residents if they can't advocate for themselves, or letting them advocate for themselves if they can. And being flexible in how we can do it, to testing things, break the rules, challenging, but thinking about how we do that with a lot of thought. And resident groups being involved to co-produce, so the co-production involvement of everybody coming through again. People engaged and motivated to take risks, make change, and push the boundaries, and involving residents in action. So actually, having gone through that, what themes are you hearing? You're hearing engagement, you're hearing risk-taking, you're hearing involvement, you're hearing co-production, getting things together. So hopefully, you're learning something that you know a lot already, and this something that we did as part of CHIP was really just building on that.
Brilliant, thank you. Unfortunately, the time isn't in our favour today to go through it, but just to see the amount of colour and the amount of writing on there, and there are some duplicates, but there's also a lot of really, really original, different thoughts. It's about getting that creativity in you going. It's also about recognising that let's not look at what we can't do, let's look at what we can do. That's what we're taught to do with the people we support. Look at what they can do, look at the strength space. Let's do that with what we do. Let's not put a cap on it and say, can't do that because. What can we do? We can't take somebody perhaps on a Mediterranean holiday, but we can go out for the day. we could sit in the garden, we can just make their space that they look out the window a bit more appealing, make sure the windows are clean, make sure they've got, you know, sometimes it's little things. If it's bigger things, then think about researchers being involved, to perhaps go on from there so that we can make a massive difference. Now, I gave you a little post-it, and the little post-it, I said it was a very special post-it. It is, because what we want you to do is just to jot something on there that you want to take away to do. It doesn't have to be to change the world, but, you know, feel free. It's about you taking an idea. So it might be somebody said about hairdressing, that you explore that a bit more. Which of your staff are trained hairdressers? Loads of carers were trained hairdressers. What can you do that's going to make a difference? It might be tiny, it might be huge. But one thing, and that's for you to do, and I would really strongly suggest you put a date on it, put it with your stuff from here, because you'll need that for your, you know, CPD folders and whatever. And look at it. Put a note in your diary for 2 months' time. What have you done about it? Because if you don't, you won't be reminded and you'll forget. And that would be a real shame, because I'm sure that right this minute there's loads and loads of positive ideas going on there. Our contacts are just on there. Just if you need them for anything. We're really, really appreciative of your time today and of joining in, and to everyone online as well. Feel free, this doesn't exclude you. And if you do want any more information about CHIP, both myself and Susie are the co-chairs. I'm not sure how that happened, but there you go. So we're both co-chairs, and we're both more than happy to have a chat about them. I don't know if we've actually got time for any questions, but have you got any burning questions that you did want to ask just now? If not, as I say, we're not rushing away, although I'll probably be by the penguins, I would imagine, at some point. Yes. Sorry.
Hi, I'm Lucy Johnston from Napier. I'm a member of CHIP and a senior research fellow at my university. And I think what's interesting for me when you see that and you're talking about that, you know, and you're thinking, well, research in care homes, how does this kind of discussion, for me over the last 4 years, getting to know the CHIP members, has been about how do I target my skills to a need or a priority or a, you know, a gap, so that I find I'm pitching my skills to you rather than trying to make you want to be part of my research, you know. So we're actually saying what do care homes want to do, and here's a supportive infrastructure within which people like me can do research and then do the other things which are about publishing and, you know, things like that. But it is actually that applied research is nice to have a home. And we talk about academic homes, but it's nice to have an applied research practice-based home. And that's part of what CHIP is to me.
It is. I really appreciate that. Thank you, Lucy. And I think it also breaks down the barriers, because Lucy's a person. Who knew? Because if you're not involved with research and stuff, you're a scary bunch. I don't have a degree. I didn't do my nursing degree. So when you're talking to people with PhDs, it would be very easy to feel inferior, but you don't, because you're the experts. You're the people they go to, and it just amazes me that there's a couple of things that we said, and Lucy's like, what's that? Like, how do you not know? Because of course you don't know. She's learnt a lot. Whether she wanted to or not, she's learnt a lot the last while. But it's lovely to know that you're the expert in that, and it's really nice to have that validated.
Any other thoughts or questions or comments or other things you'd like to feed back to us or ask? We're really open to anything, pretty much. I don't know what the lottery numbers are, sorry, can't help. Go on at the back. Have we got money? No. I'll ask. Just give us 2 minutes. We're just finishing off. Is that all right? We're back in here in 2 minutes. So we didn't. The first trip wasn't set up with any funding. We just did it out of our own time we were doing other things with. Obviously, ENRICH does have some funding for the core members of staff that we have, but and a little bit of additional funding to support events like this. We'll see what we can do. As it progresses, we need to see what money is really needed, and like you say, pay back for time that people have put in, and value that in other ways. But we have the infrastructure to support to support what it is, but in terms of cold hard cash, it depends on what you need. And so I think it would be a conversation about what people need, but we can certainly help to support that and put people together. So if you're interested in doing more, we've got a little bit toolkit that Maria's put together about how to set up a chip, how we did that before, and we're really just happy any of you who'd like to just drop us an email and we can have a conversation. It can go nowhere, it can go somewhere, but we'd be really happy to have that conversation. And just as you're writing down on your post-it to take away, I've got the one last question up here.
Hi, I'm Elsa, I'm an OT in the care home support team. I was wondering about, once you've kind of conducted the research and you've got some findings that potentially show like a gap in service or a part of service that could be improved, what sort of links then does that take to take that forward? So say that might lead into actually we want to trial this now, we found a gap, we want to trial it. How would we, like for example myself and my colleague here, we're in a care home support team, how might we find out about that to think actually that's something we could link into? Or, you know, we've also noticed, say it was about stress and distress, for example, we notice that all the time. How could we then take that research findings forward into actual practice to improve the quality of care?
I don't think I can answer that in 1 minute, but it's a great question. I mean, I think it's really important, isn't it, to think about how things get back into practice, and I think that's why we have to have these collaborations and we have to work together with the people on the ground and making that translational research. And as Liz was talking about earlier, you know, service implementation and so on. We're trying to make ENRICH at least try and be able to have that information so as we can share that, but we can't do everything. So we'll have to create those links as we grow. We've only been in existence for a year. So, you know, we're trying to learn what will work and who will work with us. So if you want to work with us and make those links and make the infrastructure so that we can pitch to CSO and Scottish Government for the funding to try and make that infrastructure work, then we need to know the people who are interested in doing that, so get in touch. Brilliant. We probably need to let the whole gaggle come in. They're pounding at the doors. So thank you very much for your attention, and we'll enjoy the rest of the day.
Are we just about ready? Yeah. Right, everybody, we're heading to the final leg of today. So it's my great pleasure to welcome Jan Beattie, and she's from the Scottish Government, and she will tell you about policy and strategy. So, thank you, Jan.
Thank you. Good afternoon, everybody. And can I say well done on staying this long? When I came in there, I was like, oh yeah, there's the usual 6 men and a dog for the last couple of sessions. And then everybody piled in, so it's really impressive. I'm really delighted to be here. Just a little bit about who I am and what I'm doing here. I'm Jan, I'm a professional advisor at the Scottish Government, mainly working in the dementia policy unit, but also in doing some work on care homes. And it's really lovely to put some faces to folk that I've seen on Teams meetings over the last couple of years. We are all human after all. So a bit about that. What the hell is a professional advisor at the Scottish Government? So I'm a sort of temporary imposter / disruptor rather than a permanent feature. So there are a number of us who have a particular kind of knowledge, experience, background, who go in and advise the civil servants and ultimately Scottish ministers on policy. And what I was asked to do today was to kind of almost wrap up what happens to research and how research informs government policy and strategy and all that stuff that then comes back out to you that you all love so much from the Scottish Government. So that's what I'm going to try and do, is make that connection between what you've been talking about this morning and in your workshops this afternoon, and what then happens to that when the government kind of takes it on and then thinks about what should happen next, whether that's in care homes or whatever else. I just really, I've got a particular passion for action research and participatory research. I am not a researcher, by the way, and like lots of people in the room, I'm a wee bit intimidated being in a room with loads of researchers. But I really like to see whenever there's any kind of research going on in any sector, in any place, that the people who participate in it get something out of it themselves. And I just really like this photograph of these two lovely ladies just having a really nice time, but obviously, you know, doing some stuff with virtual reality or whatever. And I really like this quote from one of the early German social psychologists, who was also very influential in talking about action research and people being actively involved in research as being an outcome in itself, as well as what we then can take away from it. And I'm always very conscious as somebody coming from the Scottish Government that it's not just about taking things and then, you know, churning them back out in incomprehensible language back out to you. So I'm really quite committed to that. But because we're at this point of the day and you've had, you know, about 190 PowerPoint presentations, I did want to try and have a bit of a conversation here as well. So I hope you'll indulge me. Can I get a bit of a shout out from anybody about what kind of policy you've seen which has been informed by research directly? Any kind of, whether it's in you know, the care home sector or any kind of environment where you can say, yeah, that bit of research has really shaped that policy and you can tell. Has anybody got any examples over there? Okay, the siren study. Okay, yeah. And what was the policy change? Just because I'm not familiar with it, so, or others might not be either.
Siren was basically fortnightly PCR tests to
Right, yeah, great, thanks. So a specific COVID example, yeah.
This isn't quite finished yet, but there's a Scottish Food Nation bill before the government, and my wife works for an organization that they do research into food, production, consumption, distribution, sustainability, all those kinds of things. And so a lot of the work of their organization is sort of eating into that bill before the Scottish Parliament's bill.
Brilliant, so that'll affect food availability, sustainability, what
Kind of, well, at least the organization that my wife works for is called ENRICH Scotland, and they look at kind of all ends at how supporting small growers, supporting healthier eating habits on the part of people, try to reduce carbon emissions both at production and distribution stage, there's a thing called food deserts where parts of Scotland where
yeah.
there's no fruit, no vegetables
yeah.
or anything like that. Try to get into changing behavior in those regions.
Okay, brilliant. So we've got COVID, food, any more?
I come from a palliative care background, there's so much research
Yeah.
is in palliative care, just medicines and symptom management, actually palliative care services has been driven for the lot of dramatic healing as a big research.
Yeah.
Palliative care guidelines that clinicians use for symptom management, so
Yeah, absolutely. Okay, I had a few examples just in case there wasn't going to be any. The 4 harms approach to COVID, which talked about direct health impacts and indirect health impacts, economic impacts and social impacts. And my best pal runs pubs. They own a couple of pubs in Glasgow, and she would always say to me, why can I have people in the pub eating but not drinking? Like that just doesn't make sense. And that whole kind of 4 harms approach around, if people aren't drinking, actually they'll follow rules, and if they are drinking, they won't, all that kind of stuff. So that was very much, lots of studies, a plethora of studies fed into that. I also wanted to say a little bit about, I feel like I'm now talking about alcohol quite a lot this afternoon. So I also wanted to say that the World Health Organization research on alcohol deaths and the harm caused by alcohol absolutely led to Scotland's minimum unit pricing policy, which was, one of the first, if not the first, in the world. The independent review of care, and because I was thinking about this as a care sector, I also thought about the promise, which is around looked after and accommodated young people, and how that review really has changed what kind of care those children and young people who are vulnerable are now going to be receiving. And dare I mention the independent review of adult social care? Maybe, but that's one that the promise is already much further on from that. And I also think about some of the research that's been done, and I think there's people here from University of Edinburgh, UWS and other universities who will have done some research into brain health that is really changing the narrative and our understanding about what dementia is. Because remember, dementia used to be owned by psychiatrists in the mental health world, and it's actually an organic brain disease, so that doesn't seem to make sense. So that research is really changing how we think about dementia, and I am going to say a little bit about dementia now, because we are starting, and a couple of people have actually approached me today, which I was hugely heartened by, who knew that everybody knew about it already. We are starting the development of a new national dementia strategy in Scotland, and we really see the need to learn from what has gone before. This will be the 4th national strategy, and it's just got to be different for a whole variety of reasons, but not least because of what the research has taught us since, well, I don't know, 18 years ago when the first dementia strategy was developed. And so I wanted to just say a little bit about what the process of that is, and then move on to how we might engage with research in this. So the approach we're taking to this is, and I'm not going to say we're co-designing or co-producing, we're having lots of conversations with people, we're engaging with people. Ultimately, people in the government will probably actually write it, but if I've got anything to do with it, it will reflect the conversations and the learning that's been had, not least the learning from the pandemic. So to help us, we have a lived experience panel, and actually you've already met somebody from the pre-lunch session, the Rich Voices, where Martin is active in our lived experience panel, and we have an advisory group of people who work across the dementia sector. We've got 70 engagement events and conversations. We've got a real focus on equalities this time and inclusion, because previous strategies just haven't. And again, what we've learned is that there are particular social minority groups who are particularly affected and particularly excluded from dementia support services, as well as that community support and that peer support. There's loads of learning from the pandemic. None of it makes you feel particularly proud about what we have done in policy terms, but a lot of learning about how really grassroots community support stepped up when statutory services just closed their doors. So there's a whole load of learning around that. We also want to bring in practitioners, so people who have, and I spoke to somebody this morning who I know wants to be part of this. We want to bring in practitioners to learn about what the latest dementia practice looks like. I've been in the government for 2.5 years now, so I'm 2.5 years away from practice. And things will have changed since I was doing it. And the other thing we are doing is a review of the research on dementia, with a particular focus on the things that we have learned so far. And why are we going to take this research? Why do we want a research review? Why do we want to know what the latest research is? It's the proof. And it's evidence. And when we develop a new national strategy, it has to be based on what the evidence tells us. We could sit in a cupboard and write this now, because we think we know what people need and want, and we've got lots of learning. But we need evidence to back up what our intuition is, what our insights are, and what some of the ideas are. And there are, like everything, and within the care home sector, I think it's a really good example of having a myriad of views and expectations and perceptions of what's right, what's good, what constitutes quality, and what should happen next. And the world of dementia and dementia policy and designing responses that support people to live as best they possibly can for as long as possible with dementia is there's no shortage of different views and priorities. So the research is the evidence that will help us decide what the priorities are. Because one of the things I've learned about working in government, and that's 2.5 out of 3 years, not that I'm counting, that I've been there, is that government ministers do not want to hear a whole plethora of views that they then have to kind of work out and be seen to be favouring one thing or another. They want very clear guidance on what the latest thinking is, what's definitely going to work, what's going to be value for money, and what's going to give them the most bang for their buck, especially when we're in a financial bit of a crisis at the moment. So the evidence will give us that. So that's why we're conducting an evidence review and bringing some academics around the table with us. And there's new science all the time. There's new learning. You know, the whole narrative about brain health is really only happened in probably about the last 3 to 5 years. So there's new science all the time. There's new practice all the time that a lot of you have been sharing today. I was, looking at the posters down in the bake-off tent. What's it called? The marquee. The marquee. It's like the bake-off tent in the marquee. Sorry. There's really good practice going on that folk are sharing. So we need to learn from that, and we also need to learn from what the lived experience is, because that has really changed and really been affected by the pandemic. And so we need to extend our understanding of all of those things to design and develop a new national strategy, which will determine where the money for dementia goes. We also, Scotland, believe it or not, is a global leader in dementia. We are seen as absolutely up here in the way we approach dementia. We were the first country in the world to adopt a human rights-based approach to dementia. And we remain the first country in the world, the first and the only country in the world where people are guaranteed 1 year post-diagnostic support from a named person on their diagnosis of dementia. We'll not get into the percentage of people who actually get that delivered, but the policy is fantastic. And it really enables us to be open to scrutiny and accountability. Government is accountable to the people of Scotland. So when we develop a strategy that the resources, the money, and the energy all then comes in on the back of, we need to be accountable for that. And I need to support a minister to stand up in front of her or his electorate and justify how they're spending the money. So that's what we're using research for. So the research that you are involved in, it is directly contributing to this. There's absolutely no doubt in my head about that. What have we learned so far from, as we're developing this new strategy, and it's literally been since, September that we've been working on this, and we're due to publish in April, so it's pretty speedy. Something about the grassroots support that really stepped up, and I don't know if anybody here was involved in that, but folk in their streets who were delivering food to folk during the pandemic, just knocking on folks' doors to see how they were doing because care at home services were effectively suspended. I'm guessing there's some people in this room that have been involved in community support during the pandemic. We've also learned that connection and relationships is really, really critical. And I was so heartened this morning in all the presentations where relationships is so, you're so focused on that. And that was hugely heartening. And I thought, we're not completely off piste. These are folk that are doing it. These are practitioners. And they see the real importance of connection and relationships. And that's relationships amongst people who are living with dementia and will get support from each other. It's about people who are delivering a service, like a lot of you, and the relationships that exist between just on a human level. And I said to some colleagues from Dundee earlier that actually what you guys offer is love. My mum was in a care home for 11 years, and the care home became her family. She loved them, and they loved her. And that is the most fundamental human relationship there is. And our new strategy will need to reflect that, because we've learned that. And if we don't reflect that, then actually we're failing all you, we're failing all those people living with dementia. And, you know, it gets a bit tricky when you're in the government and you talk about love. You know, they're a bit, but we're doing it. Then that whole, you know, that human rights-based approach about upholding people's rights and their choice, that will need to be in there as well. Brain health, you know, I talked a little bit about that already. And then we really want to focus on outcomes, the so what questions. So we're going to say we're going to do X, Y, and Z. We're going to say everybody who gets a diagnosis of dementia will get 1 year's post-diagnostic support from a named person. But actually, if we've only ever got halfway there in terms of people actually getting it, so what? Is that the right policy? If we haven't got the power, the control, the influence, the money to put into that policy being delivered, is there any point in having it? So that's what we have, as we are developing Scotland's new dementia strategy. We've learned quite a lot of this so far. And there will be more to come because we're doing this big review. But I wanted to just ask you what you think is missing from that. So what are we missing in terms of some of the research that you are either involved in, and there's loads of researchers in the room as well. What are we missing if you think about changing people's lives, giving people who are living with dementia the best life possible, and Scotland being the best place to live with dementia, what are we missing in terms of taking in your research and feeding that in?
Yeah, you talked there about love, kind of people going above and beyond for love, and through the pandemic, all those great and wonderful things that everybody's done. But the danger is that from the government point of view, as soon as they start to be being done a lot, it almost becomes expected, it almost becomes the norm, but that's not sustainable. So at some point, if that keeps carrying on, the people that are doing that, they get burned out, they lose the motivation, they lose the will. And if it's things that should be being done, yes, there's an element of goodwill, but the reality is that that's seen as the way to do things. That resource needs to be costed and funded and supported. The government can't go taking advantage of that forever because of the knock-on effects, especially in the care sector.
Yep, absolutely. So what's the evidence? Where's the evidence that we can use for that? I suppose, you know, this is a focus on research, this conference. So where is that we can use, if you think we're not currently using it?
I wouldn't be surprised if some of those messages have come through those that have interviewed carers and in the care homes or in the care at home or even out in the communities. I'd imagine some of these messages that I just mentioned, they must be in there somewhere.
Yeah.
So I suppose it's pushing them a bit more higher up to that one page succinct that all they want to see page.
Yeah. Okay. Jenny?
Sorry, can I just, because people online can't hear you if you don't have the mic, but I didn't want to walk in front of the screen 100 times.
Over time.
So, Jan, I feel that it's missing something about how specialist dementia care is, and I guess we've kind of come to a place of maybe attention, because lots of people have dementia and lots of people can be supported in multiple settings, but that recognition of how specialist your skills need to be to care for someone with advanced dementia, particularly in a care home, perhaps. But I guess that acknowledgement of if you get diagnosed with cancer, we don't necessarily just expect everyone to kind of rally round, muddle through, spend 10 years supporting you in your journey, and when you really, really need it, there's all these services available, and that kind of parity isn't there. And okay, we're not going to get that scale of Macmillan nurses for dementia. We know that the challenge is too great, but something that acknowledges the complexity of need, the specialist skills of the workforce, be they in care at home, be they unpaid carers, be they care home staff, to make it okay to need that help, to make it okay that we can't all just do a wee bit more, because actually it's really, really specialist work. And there is lots of research that shows that internationally and elsewhere, because care home residents don't get post-diagnostic support, their families don't get that help in preparing them for the journey ahead, even though we know some of the pertinent things that might be there. And so I guess I'd really like to see some recognition of the specialty, which is dementia care, the professionals who work in it, and where they sit in the health and social care landscape, and therefore the need for us to support everyone to do that better, rather than just thinking we just all need to bring our relatives in-house, and if only the days when women didn't work, the world would be a better place, which sometimes is the narrative in the media, and it's so much harder than that to do it well, as all of you know.
Yeah. No, thank you. Okay.
More question.
Yeah.
Thank you. This possibly will already come out when you're speaking to people with lived experience and the advisory group, but I think it's really important that the strategy sort of takes a holistic approach to living with dementia, including all the various kind of community initiatives that help people to live well, including things like creative activities, outdoor activities. I'm quite biased because my background is working outside with people with dementia, but I think it's really important to include all of those things and not to kind of just focus more on kind of brain health and sort of acute kind of care kind of things, just to look at the whole life that somebody lives with dementia and how we can make that the best possible life at every point in the journey.
Thank
like
you.
I say, that possibly will come out in a lot of the conversations.
Yeah, and it has, and it does, and we're conscious of it, but it's always really good to hear that perspective, so thank you.
I'm really sorry, but we've run out of time for
We're over
questions.
time.
I know there's a few people wanted to still ask questions, so please post them to us and we will put them to Jan and put the answers out to everybody.
I'm there.
Okay. So I'm really sorry that we've had to do this. So, shall we move on? Because we're on to the last person, which is Donica. Thank you, Jan. Thank you. And Donica was in the bake-off tent, as it now has to be called, doing some walking speed. And the reason that this is interesting is what he was doing was research. Now, if anybody took part, it wasn't that difficult, was it? It was pretty simple. So I'll let Donica take over. Thank you.
Nice one, thanks very much. And I'm conscious that the pandas need to get seen, so I'm going to be as quick as I can. But yeah, the main thing really is thank you. You've all, loads and loads of people today have taken part in research that could well get, it is all getting gathered and could well feed into policy changes somewhere down the line, a long way down the line. This is early stage stuff, and I'm just going to explain to you why I'm measuring walking speed and what that could be useful for. So there's more and more research coming out that people who go on to develop dementia, if you look at what their walking speed was many years before, sometimes 20 years before their diagnosis, it seems to be lower than the average for their say their age and their gender at that time, or their height, whatever way you want to stratify. And it's not known why that is exactly. There's lots of different hypotheses. But it is if you factor in, that they haven't had strokes, that they don't have Parkinson's disease, they don't have arthritis, all these other, if you rule all that out and they're still slow walkers for no good reason, there is more likelihood to go on and develop dementia and other negative health outcomes. So what I'm trying to do is figure out why that is, if it's a real connection, if it's causal, if it's just an association, or if it's completely down to confounders that aren't yet factored in. But as well as slow walking, and in order to know if you're a slow walker, you need to know what the average is for the population. And there is no reference speed yet for different age groups in Scotland. Some countries have done it, and it's important that you vary it, but you do it in each country, because there's not much point in comparing a busy place that's quite cold and it's okay to walk really fast to somewhere. I lived in Malawi for a year and it was very hot. It was 45 degrees and I generally wasn't in a rush to places quite as much as when I'm here and it's cold and you want to walk fast. So you need to kind of compare within countries as well. And Scotland doesn't have that just yet, and what we're doing is just trying to get a baseline so that you can then work out, well, this is the slow cutoff if you're a 40-year-old female in Scotland. And you probably need to work it out city by city and rural as well, because there's usually difference between rural and city. But not just walking speed, but if you combine it with a self-reported cognitive complaint. So that's a subjective cognitive complaint. So it's the kind of thing of, yeah, my memory's not quite what it used to be, but if you do your test, your MMSE test, or whatever the long cognitive test is, you score fine in it and you pass. But you just notice something not quite right. You know, I'm not quite, I keep losing things more than I used to. Combine that with slow walking speed, significantly slow walking speed, and you get motoric cognitive risk. And it's a syndrome that's been researched for about the last 12, 13 years. And it shows that, you have about a 3 times risk of going on to develop dementia if you have MCR earlier in life. So this is sort of where it's perceived to be. So it's before mild cognitive impairment or before any results show up on any MMSE or ACE exam. So it's just you're a slow walker for no good reason and you have a subjective cognitive, you know something's not quite right. You have MCR and you are absolutely not definitely going to go on and get develop dementia, but you're about 3 times more likely to at the way we're thinking of it at the moment. And why is that important? It's really important to identify high-risk states for lots of reasons. I've put it number 4, but it's probably the most important, that when people have been researched and asked, well, would you want to know if you're at high risk? There is a lot of people who don't want to know, but the general consensus is, yes, I would like to know, or I would like the option to know about planning for the future or all these other things. Maybe I could address some modifiable risk factors. If I smoke, it might be that extra nudge I need to stop smoking. And it's this concept of MCR. I'm a clinician, I'm a psychiatrist, but I was a physio first, which is why I'm kind of interested in this area. But the concept is really clinically relevant because you saw today, that was the longest part of it, that what we did today. That's the long bit, the measuring the gait. And normally in clinic you wouldn't have the information form and the consent and things. But that's all it needs, a hallway tip. You can see how this could translate to places where there aren't MRI scanners and you can't do lumbar punctures and things. So it could be quite a useful sort of a clinical tool. And as I said, this isn't sort of replacing MCI or anything like that, but it's a useful thing that could be an adjunct to it, so used alongside it. You can imagine GPs measuring it and determining if someone is MCR or not, and MCI, and then referring on to a clinic if needed. And you can see how somewhere like Malawi, where you can't, there aren't psychologists as such, there's a few, but you couldn't get your proper neuropsych workup. And you can't have your bloods taken for B vitamins and all the other necessary things and have a CT scan of that. But MCR might be just one way of stratifying in that population. But this is really what you're here for. This is why you stayed on. So I've kept you on your tenterhooks long enough. And what I've done is pooled everyone's data today, and there were 40 people today added to it, and I added you to a cohort at the conference the last time. So that's really good work. And thanks really mainly to Leslie for being there and handing out the questionnaires and really kind of gently friendly coercion of everybody to take part. But it was mainly females, it's mainly women here today. So the numbers are really good, but you're in blue, you're Scotland, and you're in blue. I couldn't get it in blue and white stripes or anything, but there we go. And you can see how you're faster. So on the up and down, the vertical axis is the usual walking speed of meters per second. And so across the age group, we're faster walkers here than the global average. So that global average is like 22,000 people pooled. So that's a really steady average. And we do tend to be quite a lot faster walkers, but we're kind of an unusual population. We're probably better educated than Scotland as a whole, or we're all working, we're all out and about, so maybe there's less of us who would be walking slowly. And you can see the same for males there as well. So the males again in blue. We had no male under 30 today, sad times. I didn't measure myself, of course. That's why it's not up there. So that's just a wee taste of what it's like to take part in research. You can see how I'll gather much more people to get proper reference ranges. I'll get a few 20-year-olds in there even. And you can see how that can go down. And then if I write a paper on that, well, Leslie will write it and then we'll publish it together. We do that, yeah. If we did that, and then there's the reference range all of a sudden for Scotland. Now, we'd have lots of caveats and say that the majority were at a conference and there were lions and tigers to put fear into people and chase them. So we all walked really fast. But you know, you can see how that's how evidence happens. And then if you get your slow gate cut off, and then all of a sudden we can send to GPs, well, you're an Edinburgh-based GP. This is the average walking speed of a 70-year-old female in Edinburgh. Where does your person come in? Oh, they're way lower than that. Okay, and do they have a subjective cognitive complaint? Okay, maybe they have a thing called MCR. So the memory clinic would want to know about that. And that's a long way down the line, but that's sort of a wee insight into research in action. So little things to sort out. We've done it. Yeah, not quite, but we're getting there. We've identified slow rate. We'd also need to figure out what is the best kind of question for this subjective cognitive complaint, because it's so vague and there's all sorts of ways of identifying it. That would help us determine if MCR is a worthwhile addition. So it's very early work and it's all ifs and buts. And then really we'd want to figure out is if you prevent MCR or if you intervene at that early stage, do you reduce dementia later on in life? That's the big question really. So MCR, you know what it is now, a slow gait and a subjective or self-reported cognitive complaint in the absence of dementia or functional impairment. It's really quick and you see how easy it is to measure. It could be a screen possibly, but more work is needed. Please do get in touch. That's my email, and then thanks to funders and my supervisors. And yeah, that's my Twitter handle. But thank you so much, everyone, for taking part and for staying till the end. Cheers. Thanks, Leslie. Cheers.
Right. If anybody has any questions for Donica, please contact him directly. So, now, this is the time that we're nearly at the end, but not quite. So I asked Alan McNair from the Chief Scientist Office, because they fund us, to judge the posters, and there is actually a prize. So the poster competition, he says, a fantastic variety of really inspiring research on display, highlights vibrancy and potential of care home research. Difficult to pick a winner, but he has. Hear my voice, building relationships and encouraging partnerships working in Fife. Is that so? So I have a little prize for you. This is, right, I think it's photo opportunity. Well done. And finally, the thank yous to Neil, who has worked his socks off to get this, and Paula, Neil's glamorous assistant, and to all the ENRICH team, and to all the speakers today, and to everybody who's made this a real success. And thank you for coming. Now, as I said, there is tea and coffee, and I saw piles of cakes going through. So please help yourself to something, and then you're free to go and have a look around the zoo until 5 o'clock. Thank you.